Good morning, everybody. On behalf of Indian Medical Association Mumbai branch, I welcome you all for the celebration of World AIDS Day today, a webinar. Uh, I would like to speak and tell you about our forthcoming events so that you will be able to join and enjoy those events as well. On 30th December, we have got a program in the evening. uh, It's like Ye Sham Mastani. It's a musical event between 6 to 8. You can join that particular event along with your family from your home and make that program successful. Then on 20th December, we have a webinar. On 20th December, you have a webinar on we have a maybe webinar on multi-specialty CME, which you can join. We will send you the link after some time. Then on 3rd January, we have a cricket tournament in the ground of Indian Medical Association Mumbai branch. We'll definitely send you the details of that. And you can join there along with your family members also. And we have been doing it for years together, and it has always been a successful event. So you can make it successful even this year. Then on 17th January, we have a webinar along with JJ Merchant Oration and Bima Elocution Competition, the details of which will be posted to you on our wall, and therefore you will be able to join that. You can participate now. As far as the elocution competition is concerned, whether we'll take it live or whether we will take it uh, online, that decision will be taken subsequently. And last but not the least, this year we are having annual Golden Jubilee Conference. Annual conference this year is the Golden Jubilee Conference, which is posted on 7th February. Now, depending on government notification, whether it should be hybrid, whether it is going to be live, whether it is going to be online, all that details we will be providing you subsequently. So thank you very much for patient hearing. And now I hand over the proceeding to Dr. Girish Rajadhyaksha, the chairman for today's program. Thank you.
Thank you, Dr. Lal. And on behalf of Indian Medical Association Mumbai branch, I welcome you all and wish you a very good morning. Today, everybody in our organizing committee, with special thanks to our president, our joint secretary, Dr. Lal, and my very good friend, Dr. Anil Awad. These people have given you a very, very good program on the occasion of World AIDS Day. We have 3 lectures which are dedicated to HIV AIDS. One will be interesting cases in AIDS. Another thing is we all are interested in knowing AIDS when you get, and AIDS patients when they get COVID, what is the prognosis and how they behave. So there is one lecture dedicated to that, and HIV and kidney. So these are the 3 lectures which are dedicated to HIV. But in addition to that, you will also hear something about special techniques in colorectal surgery, and you will listen to advanced breast cancer as well. So there is going to be a very good scientific program for all of you today, and I hope all of you will enjoy it and will get immensely benefited. I again thank all the people, especially the office bearers of the Mumbai branch of the IMA, for doing all the work in successful organization of this World AIDS Day program. And now I hand over the mic to Dr. Anil Awad to start the scientific program. Dr. Anil Awad, please. Thank you. I hand over to Dr. Sujatinasa Attar, our president, to give the presidential address, and then we'll start the program. Thank you.
Thank you, Dr. Girish. Good morning, friends. I welcome you all today for a webinar on HIV update. Today's theme of HIV for the year 2020 is ending the HIV/AIDS epidemic, resilience and impact, which will focus on creating global solidarity and providing resilient services among people who live with HIV even during the coronavirus pandemic. Every year, 1st December since 1988 is observed as World's AIDS Day in order to raise awareness and to unite people worldwide in the fight against the global health issue of acquired immunodeficiency syndrome. It is also significant to find the stigma around it and focus on providing care and support for these who are already living with the disease. On the global level, there are approximately 38 million people who are living with HIV. It was first discovered in 1984. With this, I would not waste much time, and I'll hand over to Dr. Anil Awar, who's the Assistant Director, IMS-CGP, to continue the further proceedings. Dr. Anil Awar.
Thank you, President Madam. Now we proceed with the World AIDS Day program. The first speaker is Dr. Suhas Agre. I'll just introduce him. Dr. Suhas Agre is a consultant oncologist at Asian Cancer Institute, Somaiya Ayurvihar, Sion. After completing his MBBS from MUHS, he did MD in internal medicine from JN Medical College, Raipur, followed by DM Oncology from BJ Medical College, Ahmedabad. He stood second in the DM examination in Gujarat University. He has done many research activities and he has many publications to his credit in the field of oncology. He has attended various international, national, as well as state level conferences. He has extensively taken bedside clinics for undergraduates and postgraduate students. I request Dr. Suhas Agre to continue with his topic.
So thank you, sir. Thank you, Dr. Awad, for the kind introduction. I would like to share my screen now. So in the meantime, I would like to thank IMA Mumbai branch for giving me the opportunity for being here. And specifically everyone, including Dr. Rajadhyaksha, whom I personally know because my wife was a resident in the internal medicine with him. And again, I would like to thank everyone from the organizers team for inviting me for this special talk today. Today's topic for discussion was regarding some of the aspects related to the breast cancer. So today's topic for discussion was regarding some of the aspects related to the breast cancer and the management of the advanced breast cancer. So many people, they are wondering why on this forum of World AIDS Day, why this topic for the discussion, basically how the breast cancer has come up. So let me let me brief you something like that. So whenever now we are seeing that the people with HIV and AIDS, they are living longer because thanks to the effective antiretroviral treatment, and we have been seeing the longevity of these patients has quite dramatically improved. Second point, because of this longevity, the death rate, since they really particularly to the mortality due to the non-communicable diseases like the cancer and the cardiovascular diseases, they are forming the major chunk for the mortality among these patients. I hope my other colleagues will also agree with me on this particular aspect. And because whenever we see the majority non-communicable diseases apart from the cardiovascular diseases, the cancer and particularly the breast cancer, which is the most common diagnosed cancer, not only the worldwide, but also India. So I would like to take you through the journey of some of the important aspect of the breast cancer. So coming towards so this is the Globocon 2018 data. What it shows that now in India, this is from Globocon 2018, and as it shows, the breast cancer is most commonly diagnosed cancer among the Indian population. So not only the female, but also the entire Indian population, and it constitutes almost around the 14% of the total cases. Second, when we see about the particularly the female population, so the breast cancer it constitutes almost 27 to 28% of total cancer cases. And as we used to see earlier, it was a cervical cancer, but because of the now with the improvement in the hygienic conditions, maybe other vaccines and all, and because the incidence of the cervical cancer has gone down, and now the breast cancer is leading the number one spot as far as the cancer population is concerned in India. So what are the risk factors? As we know that now basically this breast cancer is a estrogen driven tumor. So as long as there is a continuous estrogen exposure from the start of the menarche cases are happening. And nowadays, the another factor that has really contributed to a huge extent in increasing these number of the cases is particularly the obesity, inadequate physical activity, and as well as the consumption of the alcohol and the smoking that has contributed immensely in increase in the number of the breast cancer cases, particularly in the urban population. So apart from that, whenever there is some of the family history, so whenever there are some of the genetic risk factor, when we talk about almost 10% of the breast cancer cases, they are related to the genetic factors. One of the most commonly noted factor would be the BRCA1 and 2 mutation, and we are known with the very well known example of the Angelina Jolie itself. And again, the being the personal history is important again. So whenever the patient has been affected with the breast cancer, there is a lifetime risk of development of the contralateral breast cancer, almost 2.5% or so. And apart from that, there are some other reasons like the, as we have already discussed, basically related to the lifestyle and the environmental factors. So this is the important slide to share about the genetic mutation as a risk factor. So whenever we see there is some of the familial clustering of the breast cancer cases, along with some of the other common, maybe like the breast cancer, ovarian cancer, there might be other cancer like the endometrial or the colonic cancer. In that particular cases, particularly with the young age of the onset and the triple negative breast cancer history, we usually like to evaluate or the particular familial inheritance of the breast cancer. So as whenever we discuss about this familial predisposition, so most important will be the BRCA1 and 2 mutation, which accounts for majority of this familial predisposition of the cases. But there are some other factors, other like either a P10 check2 or TP53 mutation, which are responsible for some of the uncommon kind of familial predisposition also. So whenever any of the patient is presenting to us, particularly at the young age, they are giving a strong family history of various types of the cancer, not only the breast, but also the ovarian, colonic, endometrial cancers. And particularly the triple negative breast cancer, we need to evaluate the family history in that particular case. So now coming toward the some of the common site, as we know that there are various sites, but when we see in the clinical practice, when we see in the clinical practice, so the upper outer quadrant is the most common site for the breast cancer development. So this is the upper and the outer quadrant, which is almost responsible for 57% of the breast cancer development. And when we talk about the what are the various histopathological subtypes, either they may be a non-invasive or the invasive breast cancer. So obviously, among the invasive breast cancer, the 90% of the cases, they are related to the invasive breast cancer, that is called as we call it as invasive ductal carcinoma. And rarely, less than 10% of the cases, it may be a lobular breast cancer. So one of the important aspect with the lobular breast cancer is that they are usually tend to be bilateral in the nature. So whenever we are encountering this histopathological diagnosis, we should not forget to look upon the contralateral site also. So what coming towards the various presentation. So common problem with the breast cancer is that they usually present with either penless swelling. So penless swelling either in a breast or axilla, and this has led to delay in the diagnosis, because many of the times the patient think that because this is a swelling, just and swelling, or any other finding as such associated with, and that is what it is neglected over the time period. And ultimately, whenever it is associated with some of the symptom, like whenever there is a skin involvement, there will be discharge, nipple retraction, maybe some distant metastasis. At that time, usually these individuals are being brought to the hospitals, and ultimately this lead to the delay in the diagnosis. So this is a factor which is important factor, that is asymptomatic and usually a penless swelling, that is usually particularly in Indian context, it has related to the led to the delay in the diagnosis. But now I should acknowledge that now this has been story a decade before. Now we are seeing a majority of the patient who are being diagnosed, who are coming to us in the very early stages. As soon as they feel or they notice any lump in the breast or the axilla. So apart from the common presentation of the lump or the mass in the breast or axilla, there would be other common symptoms, like either there would be a skin dimpling, skin retraction, nipple retraction, thickening of the skin of the breast, or sometimes the redness of the skin of the breast. This is called as inflammatory breast cancer. Just to summarize, all this will can be a presentation of the breast cancer, ranging from a mass, maybe a indentation, sometimes the erosion of the skin, sometimes the redness of the skin of the breast, or some abnormal discharge, maybe the dimpling and the puckering, what we commonly call it as a pudi orange appearance. Sometimes there might be involvement of the lymphatics and the dilatation of the veins, retraction of the nipple, and maybe the invisible lump sometimes, or sometimes they simply present with a palpable mass in the axilla without any mass in the breast. That is called as primary axillary breast cancer. So apart from these symptoms common which are related to the localized breast disease, sometimes they may present with symptoms related to the metastasis. Suppose this patient, common site of the metastasis would be the bone, maybe the lung, maybe the liver and the brain. In that cases, the individuals may develop a symptom related to that specific organ. Like sometimes the patient may present with the unbearable back pain that is not getting relieved with the usual remedies, or sometimes they may present with some breathlessness, cough, and maybe the difficulty in lying down. In that cases, there might be a malignant pleural effusion, or maybe the symptoms related to the brain metastasis. So in that particular case, whenever these individuals are presenting with this advanced symptoms related to the metastatic disease, we have to evaluate a breast as maybe a primary possible etiology. So diagnosis of the breast cancer. So apart, whenever we suspect all these cases, suppose with this lady we are able to identify as a potential candidate or maybe harboring a breast cancer. So in that cases, how we would proceed would be the doing some of the common diagnostic tests and followed by the treatment approaches. So coming toward the screening part of the breast cancer, because this is a very important aspect, and this has really enlightened, this has improved the awareness among the general population. And now we also see that many of now these people, they usually try these various methods of the screening, and they usually then this has led to the early diagnosis also. So whenever we talk about the screening methods, so these are the some of the simple screening techniques like breast self examination in the resources limited countries like India, where I think having a mammography facility also is very difficult. I can see the some of the interior places in India or in Maharashtra itself, like some of the district places where the mammography facility is not much available. So in that cases, maybe either doing a breast self examination will be an important tool. And how it helps is that it will help us to detect a small lump whenever possible, and accordingly we can investigate it further if we find it out any abnormal thing. Similarly, this breast self examination has been advised starting from the age of 20 years to be done at least once in a month, while the clinical breast examination by the healthcare professional has been advised doing every 6 monthly. Apart from that, whenever possible, whenever available, the mammography remains a gold standard as a method of the screening, and it has been advised to undergo a regular mammographic screening after the age of the 40 years, once in a year or maybe once in 2 years in countries like India also. So what how that screening help us? Suppose that whenever any individual, I can give you an example. There is one female individual who is trying this breast self examination occasionally, versus a lady who is trying to do the breast self examination at a very regular interval. So this would be the, so whenever how this breast self examination that will help the individual to get adapted to the breast anatomy and the parenchyma, while so who is practicing occasionally will be able to detect a lump of bigger size, maybe of lemon size. But suppose who is practicing the breast self-examination at regular interval, she will be able to pick up this lump at a very small stage, maybe a small, even a size of the peanut. So apart from the so radiological various method like the mammography we already discussed. Whenever mammography not available, maybe we can take the help of the ultrasound of the breast, but this is not as such reliable as the mammography. In case of breast, dense breast or the young patient, we can use the MRI. While there are certain other tests like in Mumbai, like when we are having a quite availability of the PET scan. So this PET scan has been used in the either a locally advanced or a metastatic breast cancer. Currently, there is no role of the PET scan in the early cases of the breast cancer, but definitively for a locally advanced and the metastatic to define the proper staging of the breast cancer. So apart from the second step would be taking a biopsy. So either many times we find that the FNAC as a method like fine needle aspiration cytology, but that is an individualized cytopathological driven method. Nowadays, we definitely prefer with the biopsy. So one thing is that it is very reliant as such, and second thing with that, we want to test the hormone receptor status called as ER/PR/HER2, which are the principal prognostic and the predictive factors in the breast cancer management. So these are the various techniques, and what we commonly do is the true cut or the core needle biopsy that has been advised. But whenever there is an uncertainty or discrepancy between the histopathological and the radiological finding, we can go ahead with the excisional biopsy also. So I won't go into the detail of the staging much. Only I would like to highlight this important factor that we can see from this slide how the survival rates can differ from the stage 1 to stage 4. So this is usually a 5-year survival. Whenever any cancer patient is diagnosed, so either a patient or their family member, they ask us, "Saab abhi kitne saal jinda rahega?" So that is called as what we talk it as a 5-year survival rate. And as we can see from this figure, for the stage 1 it will be as high as 90%, but as we move on from the 1 to stage 4, it will be hardly a 10 to 14% in case of stage 4 patient. So what I think important is the early diagnosis is the key of the breast cancer. So earlier diagnosis will lead to the earlier increase in the cure rate and ultimately improving the total survival and the outcome for the breast cancer management. So whenever we discuss about the treatment of the breast cancer, there will be two modalities, either a local modality or a systemic modality. Local modality will include the surgery and the radiation treatment, and which will be followed by the systemic treatment based upon the final histopathology report. So being a medical oncologist, so various roles of the chemotherapy will be either in a localized early stages breast cancer as a modality of the adjuvant treatment to take care of the micrometastasis, while if it is an locally advanced maybe a fungating breast mass, so in that cases our surgical colleague will tell us, okay, now it is looks inoperable, can you downstage or can you shrink that by giving the chemotherapy? So it is called as neoadjuvant chemotherapy. So basically there will be two approaches, either a adjuvant or the neoadjuvant based upon the primary stage of the breast cancer. So apart from that, local treatment will include a surgery, and as we know nowadays there are quite a advancement, when what we used to see after earlier MRM was only modality of the treatment. Later on it was found that they used to develop a depression post treatment psychological issues and all related to the loss of the breast, and how this concept of the conservation of the breast has come up, and this has quite significantly improved the psychological aspects post post completion of the treatment. So either a breast conservation surgery or a modified or the mastectomy, so both these did not differ in case of the outcome, but ultimately there are some of the aspects, there are pros and cons with each method. So whenever we talk about the breast conservation, it will be either a lumpectomy or the quadrantectomy. So what is important is that we not need to surrounding the tumor will be very much necessary, and that is what called as the lumpectomy. So mastectomy will include the removal of the entire the breast as well as the axillary dissection. But again, there are some of the newer modalities like either a MRM where we do the axial lymph node dissection, maybe the skin sparing mastectomy. So, and the role of the radiation will be confined in case of adjuvant setting, particularly for the bigger tumors which are more than 5 centimeters. The some of the node positive tumors like maybe 3 or more are nowadays, even for the small early 1 or 2 nodes also, and the margin positive breast cancer, or in case of there will be the radiation treatment will be mandatory after the breast conservation surgery. So what is important to remember is that suppose there is a small lump, maybe a 2 centimeter node negative. In that case, maybe a elderly lady who is having not that kind of access to the healthcare facilities for the radiation treatment, in that cases we can offer them the modified radical mastectomy instead of the breast conservation, as later on the breast conservation cases has to be followed with the radiation treatment. And if we can do the MRM in case of small tumor, then we can spare it from the adjuvant radiation treatment. So we have to select our treatment modalities on the case by case basis, depending upon the financial aspect, maybe the availability and access to the healthcare facilities also. So coming towards the some of the important aspects, so the adjuvant treatment after the now a final histopath report, whether it will be a hormone positive, HER2 positive, depending upon that we have to use various manipulations for the treatment. Like a premenopausal woman, we usually use the tamoxifen and all, while the postmenopausal we use the aromatase inhibitors. So the chemotherapy, as we have already discussed, I won't go into the detail. Just I would like to tell you that nowadays chemotherapy giving a chemotherapy is not, we are having a very good supportive care. That's why the main adverse effect that were used to be associated earlier, like nausea, vomiting, then there will be a risk of the febrile neutropenias and all. Nowadays this has gone significantly down because of the very good supportive care. Like we use commonly the anti-emetics in the advanced, like then we use the prophylactic WBC booster doses that has bring down the complication rate to a great extent. Now in our clinical practice, what we can see is that maybe majority, almost 90% of the patient, they are leading a normal life, and maybe 5 to 10% of the patient, they may develop some of the minor side effect, that also not to a higher degrees of the complications. So now, apart from the chemo and the hormonal therapy, what has evolved over the last decade or so is the targeted therapy. Earlier, whenever we use no, there was no practice of routinely doing a HER2 testing in the breast cancer. When I talk maybe about 15 years or maybe so, but as gradually now that there was a subset which was identified as a HER2 positive breast cancer, and it was brought to the notice that there is a now available drug called as trastuzumab, which if you can give in the adjuvant setting, that really improves the survival rate of this particular HER2 positive breast cancer. So these are the various development that has happened over the last decade, and they have really improved the outcomes for the breast cancer management. So I will just brief about some of that, how the targeted therapies has improved the outcome. So this is a basic mTOR pathway which takes care of multiple signalings. So this was a CDK4 inhibitor, CDK4/6 inhibitors, which are playing a major role in the management of the advanced metastatic hormone positive breast cancer. So when we see this is the cyclin D1 and the CDK4/6, and that ultimately lead to the cellular proliferation and cellular proliferation on the tumor growth. So when we can block it with the CDK4/6, ultimately this will control, this will check the further cellular proliferation, and this will lead to the either a cell necrosis or the apoptosis. So what was seen in the practice is that suppose the patient is hormone receptor positive breast cancer, received adjuvant treatment, and then she has progressed after a period of 1 year or so. So already we have used one kind of hormonal treatment like maybe aromatase inhibitors or maybe the tamoxifen in the adjuvant setting, and the patient has relapsed. Now what is to be used next? So there were quite a few very limited options, but over the last few years now this area has really improved a lot. And nowadays we are having a certain agent called as CDK4/6 inhibitors that has literally changed all the outcomes for the hormone positive breast cancer management. So these are the some of the few trials to mention, like phase 3 clinical trials which has come up with the MONALEESA-2. These are the randomization of ribociclib versus placebo with letrozole, while the palbociclib, this was a Paloma 3, which was a landmark trial, while there are other two trials like abemaciclib versus placebo and the aromatase inhibitor, while in case of premenopausal women, again MONALEESA-7 trial where the ribociclib with tamoxifen or aromatase versus placebo with these agents. And ultimately what we could see, this was a landmark phase 3 trial Paloma 2, which has it was the first trial to show that this particular subset of advanced breast cancer hormone positive who has progressed. And when we combine with this CDK4/6 with letrozole versus placebo, we can see the progression free survival was significantly improved. We can see almost after period of 1 month or so separated for such a long time period. As we can see that at a data cutoff of earlier, there was an improvement in the median PFS of almost 10 months, while later on it showed up a median PFS of almost 13 months or so. Based upon this trial, this drug was approved in the management of hormone receptor positive and HER2 negative breast cancer who has been progressed on the one line of the hormonal treatment. Second, this was a MONALEESA-2 trial in which ribociclib was compared with the placebo and letrozole. And in the similarly, we can see the significant improvement in the PFS. PFS at 24 months, it was 35.9 versus 54 months in the ribociclib arm. And now these are the standard practice in the clinical, these are the standard mode of the clinical practice. So ultimately, we are having a wide range of the treatment option. Suppose the patient is a metastatic CA breast, hormone positive, HER2 negative. So we can use who is endocrine naive, who has not received the endocrine treatment till now in the advanced setting. So first line, we can use a various agent depending upon these trials. While suppose even the patient who has received a endocrine therapy in the first line setting and progressed. So what are the options? There are again the second line treatment options based upon the various trials, like combination of the palbociclib or the ribociclib with the fulvestrant, or maybe the abemaciclib with the fulvestrant. And I would like to tell you that these are agents which are having a very good side effect profile, very favorable side effect profile. They can cause very mild grade of the nausea, vomiting. Sometimes major side effect would be the neutropenias and the thrombocytopenia, but that can be easily managed in the clinical practice. The advantage would be taking a pill based treatment only, avoiding the chemotherapy, and we cannot see such a kind of improvement in the survival and the progression free survival with the chemotherapy only treatment. So this was a suppose the patient progresses on this kind of hormonal manipulation, maybe a first line endocrine therapy followed by the CDK4/6, and suppose this patient has progressed, and these are having what we do now commonly nowadays is we try to identify, we do the biopsy, or maybe through liquid biopsy we try to identify a particular mutation called as PIK3 kinase alpha mutation, and if that is positive, we are having a new kind of treatment nowadays that will be called as the PIK3 kinase inhibitors. And it was shown that even in this trial also, this is drug called as alpelisib versus a placebo combination, and we can see even in the second line or maybe the third line setting, there are a good survival outcomes and improvements. Apart from that, in the era of the HER2 positive breast cancer, there are quite a lot of improvement like called as TDM1, which can improve the outcome, particularly in case of HER2 positive breast cancer. And lastly, nowadays, as we talk about the familial tendencies and the BRCA mutation positive breast cancer, and there now this drug olaparib has been approved in the management of those BRCA positive metastatic breast cancer which are hormone positive HER2 negative. And in that cases, suppose they are having a particular this BRCA mutation, germline BRCA mutation, and they have been in the metastatic setting, when this olaparib was compared to the standard of the care like chemotherapy, as we can see this with this drug, there is a significant improvement in the progression free survival also. As we can see, the progression free survival was, there was a 42% relative risk in reduction of the death, and PFS was significantly improved. Based on this trial, those who individual with the metastatic breast cancer, which are HER2 negative and the BRCA germline BRCA mutation positive, now this olaparib has been approved, US FDA approved as a method of the treatment. Last but not the least, this would be immunotherapy. As we can see, commonly this immunotherapy has been commonly being used in the management of either lung cancer, head and neck cancer, then the bladder, kidney cancers. But this was a last means place where the breast there was because being a heterogeneous disorder, and now this immunotherapy has been approved in a treatment of the metastatic triple negative breast cancers also. So although we are using this more often in other cancer like lung and head and neck, so nowadays even with the triple negative breast cancer, because there are no lot there is a paucity of the treatment option in metastatic triple negative breast cancer. So the immunotherapy, this was a atezolizumab with nab-paclitaxel. This was a randomized impassion 130 trial where this agent was compared versus the placebo with nab-paclitaxel, and the treatment was continued until the radiological disease progression. And when we can see those individuals who are having a PDL1 positivity in those particular population, the PFS was significant, median OS was improved by 7 months. So we can see 18 months in the placebo versus 25 months. So we can see even in the triple negative breast cancer who has been advanced triple negative breast cancer, improvement in the survival of 7-8 months, this achieve a very good importance in the clinical practice. And nowadays this agent has been US FDA approved for the metastatic triple negative breast cancer who are expressing this PD-L1 receptors. So lastly, to conclude, the obviously like any of the cancer, breast cancer is not an exception, and early diagnosis would be the key in the management, and if it can detected early, we can improve the outcomes. The number of the new drugs are in the development, are in the rapid development, and ultimately the targeted therapies continue to emerge with the goal of improved effectiveness, but at the same time they are having a minimal possible that to manageable side effects. Thank you for patience listening.
Thank you very much, Dr. Suhas Agre. We'll just quickly go through two questions. One question
Yes.
from Dr. Rajan Patel: is combined oral targeted chemo better than a single tablet?
Sorry, sir. Can you repeat the question, sir?
Is combined oral targeted chemo is better than a single tablet?
So, sir, there are definitively these are the what we have seen just now in some of the trial, that whenever we are combining the CDK4/6 with hormonal like routine endocrine first line treatment like aromatase inhibitors, they are definitively superior to the single agent aromatase inhibitors. That has been proven. Not only we are having a strong robust data for that.
Okay, thank you. There's one more question. With so many drugs, many oral medications, what do you think is the future of IV chemotherapy?
Yes, sir. So very nice question, sir. I think this chemotherapy is the backbone of the treatment. So, but as the advances are going on with the particularly in metastatic setting, the role of the whenever there are options of like a targeted therapies and the targeted therapies and the other hormonal manipulation, the role of the chemotherapy is going down. But ultimately, there would be a platform like the targeted therapies cannot be given alone. Suppose we take an example of the trastuzumab, so we have to combine it with the chemotherapy to be being more effective. And see, whenever there is a huge burden of the disease, when we want a faster and the rapid responses, at that time the most important agent to bring this disease burden at a rapid pace would be the chemotherapy. Because as we know that this the oral kind of formulation, like maybe the simply the hormonal treatment aromatase inhibitor, like maybe you can take an example, they take some time like 2 to 3 months for the benefits to appear. But suppose any rapidly progressive disease where we want a rapid shrinkage of the tumor, at that time we agent like chemotherapy that can give us a symptomatic rapid relief. Maybe the role, maybe the overall uses are coming maybe to a limited to means to a lesser extent, but definitively they would have their importance at some or other places.
Yeah. Thank you very much, Dr. Suhas Agre, for an excellent presentation. Thank you.
Thank you, sir.
Yeah. Now we move on to the next speaker, and that is none other than Dr. Preeti Mehta. And I request Dr. Jitesh Mehta, the president-elect, to introduce Dr. Preeti Mehta.
Hello. Yeah, good morning, everybody. Dr. Preeti Mehta is a consultant pediatric hemato-oncologist at Raheja, Saifi Hospital, HN Hospital, Jaslok, and Prince Ali Khan Hospitals. She was an assistant professor in pediatric hemato-oncology at BJ Wadia Hospital for Children. She completed her MBBS diploma and MD in pediatrics and FNB in pediatric hemato-oncology from KM Hospital, GS Medical College, Mumbai. She got the SIOP, that is the International Society of Pediatric Oncology Scholarship, for her work in thalassemia. Dr. Preeti has several publications under her name in national journals. Her expertise includes benign hematological problems, hemophilia, sickle cell anemia, ITP, leukemia, and lymphoma. Today she will be talking on changing outcomes in SAA with L-Trombopag. Over to Dr. Preeti Mehta, please.
So, good morning, everybody. Thank you, sir, for this kind introduction. And I thank the IMA organizing committee to have me here. My topic for today is how L-Trombopag has changed the outcomes in severe aplastic anemia. So my introduction has already been given, so I skipped the slide. Now I have divided my talk into 4 subtopics. I'll give a brief introduction about what aplastic anemia is, what the treatment of aplastic anemia is, and how L-Trombopag has revolutionized the treatment of refractory aplastic anemia and a newly diagnosed aplastic anemia. If we look at the global distribution of aplastic anemia, the incidence in East Asia is 2 to 3 times higher than the Western population. And in India itself, the incidence is around 6.8 per million population. Aplastic anemia affects both the sexes and it occurs across all age groups. Now, the thing is that it can be either inherited or acquired. And it is very important to know whether it is inherited or acquired because the treatment modality is completely different for both of them. So as we know, it's a complete bone marrow failure syndrome disorder, which is completely life-threatening, and aplastic anemia is depicted by a pancytopenia on the CBC, where the marrow becomes completely hypocellular because of the decreased number of hematopoietic stem cells, and usually there is an immune-mediated attack which happens. The mortality because of aplastic anemia is as close to 70% if we are just giving supportive treatment in the form of platelets and blood transfusion to the children and to the adults. And no single test can diagnose aplastic anemia. So it's a gamut of tests which are required. Secondly, it overlaps with a lot of other conditions like paroxysmal nocturnal hemoglobinuria, hypocellular MDS. So we need to be very careful that which condition are we dealing with before just embarking on the treatment. Now, if we look at the causes, the inherited causes, the idiopathic causes contribute to around 70%, and the inherited gene abnormalities are another subset, which we need to rule out before treating a person with aplastic anemia. So Fanconi's anemia, telomere diseases need to be ruled out in a case of aplastic anemia. At times, toxic and toxins like chemical damage and all that can also give rise to aplastic anemia. So now if we look at the pathophysiology, if we are dealing with a physical and a chemical damage because of cytotoxic drugs or radiation, then the treatment modality would be basically a supportive care, hematopoietic growth factors, or a transplant. But if we are looking at an immune-mediated destruction, like idiopathic causes or a seronegative hepatitis, eosinophilic fasciitis, then that's where the immunosuppressive therapy can be used. So it's very important to categorize the etiology also. And that's where L-Trombopag can be used, is used rather, along with the immunosuppressive therapy. If you're dealing with genetic conditions like constitutional genetic defects like Fanconi's, then there's no point of using immunosuppressive therapy, and the treatment modality is completely different in the form of sex hormones or a transplant. So in pediatric patients, I am a pediatric hematologist, oncologist dealing with children up to 18 years of age. what we have seen is that 1/4 of the pediatric population has constitutional genetic defects, and they have an inherited etiology. So we need to rule that out before embarking on treatment, and Fanconi's is quite common in this age group. And in young adults, approximately 10% have this condition. So as I told you that it is very important to rule out the differentiate between the inherited and the acquired conditions. Now, if we define aplastic anemia, on a CBC, we need at least 2 cell lines to be low with a hemoglobin of less than 10, a platelet of less than 50,000, and a neutrophil count of less than 1,500. And depending, the Kemeta et al. In 1976 have now further subdivided it into severity as a severe aplastic anemia, a very severe aplastic anemia, or a non-severe aplastic anemia. So what happens in a severe aplastic anemia, the bone marrow cellularity is less than 25%, or the hematopoietic stem cells are less than 30%, even if the cellularity is between 25 and 50%. On a CBC, we require a neutrophil count, absolute neutrophil count of less than 500, a platelet of less than 20,000, and a retic of less than 20%, 20,000. Very severe is similar to severe, except for that the neutrophil count drops further to less than 200. And the non-severe is the one which does not fit into this, but the absolute neutrophil count is less than 1,500. So what happens? Why do people get aplastic anemia? It is because of the activated T lymphocytes. These activated T lymphocytes secrete a lot of cytokines, IL-2, interferon gamma, TNF alpha. It is this interferon gamma which acts on the hematopoietic stem and the progenitor cells, which causes toxicity to the cells, decreases the protein synthesis, increases the apoptosis of the cells, decreases the cell cycling, and that's how it leads to a hematopoietic failure. So when a person presents with acquired aplastic anemia, because we are talking of acquired aplastic anemia today, the clinical presentation is because of the pancytopenia. If there is decreased red blood cells in the body, you will get symptoms of anemia. The person may come with fatigue, difficulty in breathing on exertion. And because of the decreased platelets, there may be skin bleeds, petechiae, ecchymosis, gum bleeds because of the mucosal bleeding, or epistaxis. Visual disturbance due to retinal hemorrhage is also very well known. Now, when we investigate a child with or an adult with aplastic anemia, we do a basic CBC and a retic count, a blood film examination. This blood film examination is done basically is very important to rule out if there are any blasts, and are we dealing with a hypocellular, acellular, hypocellular ALL. Hemoglobin F percentage will be raised in myelodysplastic syndrome. So it is very important to do. Bone marrow aspirate and trophine biopsy is a must. But along with that, we need a peripheral blood cytogenetics. PNH can be ruled out by a flow these days. Ham test is no longer done, but a flow is definitely done to rule out CD55, 59 deficiency. B12 and folate levels are very, very important, because at times a pancytopenia can be just a megaloblastic anemia, and we may think that it is an aplastic anemia. So very important to do a B12 and a folate level. Liver function test, because many viruses, like common viruses A, B, C, EBV, CMV can also present with pancytopenia. At times, rheumatological problems like SLE can come with pancytopenia. So ANA and anti-DSG ANA is very important. A chest X-ray and an abdominal scan. Abdominal scan to look at hepatosplenomegaly, because if present, it completely rules out aplastic anemia, which usually don't have liver and spleen. Now, what we see in a bone marrow is basically a hypocellular marrow. And a bone marrow biopsy is the most important thing, because the cellularity is more seen on the biopsy than on the aspirate. What we see will be a lot of fat spaces and a little bit of residual hematopoietic cells. So if you look at the normal marrow, you can see all these cells. These are the cellularity, which is completely lacking, and it's completely replaced by fat spaces over here. So this is how a aplastic anemia marrow is going to be looking. Peripheral blood cytogenetics. On the peripheral blood, up to the age of 45, very important to do, because you do either a MMC, that is mitomycin C induced chromosomal breaks, or DEB breaks. If this report comes positive and you get breaks, this suggests a constitutional genetic defect, and then there is no role of immunosuppressive therapy in this. And the treatment modality is either a transplant, because this says it's either a congenital defect known as Fanconi's anemia, Now you give sex hormones if the patient cannot go for a transplant. So if we look at the treatment of aplastic anemia, it is either a transplant or allogenic stem cell transplant from a HLA identical donor, or we give immunosuppressive therapy with anti-thymocyte globulin and cyclosporin. So if we have a child of aplastic anemia, first we rule out Fanconi's anemia, because then the child is completely off this algorithm of acquired aplastic anemia treatment. If the child fits into our acquired aplastic anemia, we either go for a transplant from a sibling matched donor if possible. If not, then we give the first cycle of immunosuppressive therapy with ATG and cyclosporin. Now we assess the response usually at the end of 3 to 6 months, not before that. And what we see is that if the child is responding, you continue low dose cyclosporin for a prolonged period. If not responding, then probably you may either go for an unrelated donor transplant or a second course of ATG. Now, what happens is that some don't respond. Either you don't have an unrelated donor, or they don't respond to the second course of ATG. And so this was a subgroup which was intriguing, who still had the severe or very severe aplastic anemia. And so it was thought that immunosuppressive therapy over the decades has not transformed that outcome much, and there is still a subgroup who still have that persistent severe or very severe aplastic anemia. And in the 80s, ATG and cyclosporin gave a response of around 60% in the group. So what more could be done? And though there was a 60 to 70% response, it was only partial response. Complete response was seen only in 10%. And so it was decided that what could be done. So the outcome of all the immunosuppressive therapy who were ineligible for transplant was tabulated, and what was seen, the NIH study, that the response was seen in 61%, out of which again 35 relapsed, and 55% was the survival at the end of 7 years. But this response, what we are seeing is also not a complete response, and it's usually 10% who are having a complete response. So by response, first we say what response means. A response is when we see an absolute neutrophil count of at least 1,000, a hemoglobin of at least 10, and a platelet of 1 lakh. If the patient doesn't have any of these, does not fit into this, then he is categorized as a partial response. And blood counts that no longer meet the criteria of severe aplastic anemia will not meet the criteria of the complete response. So most of the patients had become partially transfusion independent, but had not gone into a complete remission. So, but this was not the scenario in children. If you look at the outcome of ATG and horse ATG along with cyclosporin in children, they have a better response than what adults do. Around 50% of them have a robust response. And there are a few German, Japanese, and Chinese studies who have said that the 5-year survival is more than 90% in this people who have had a 50% response. So children, basically with idiopathic aplastic anemia, they respond better than adults, better than the adolescents and the adults. So there was a need that in those who had not responded to 2 courses of ATG and cyclosporin, what could be done if the transplant was not an option? If the haplotransplants, cord transplants, everything was exhausted, that was not an option, and a second course of ATG had also not helped. And that's where the experimental therapy came in place, like with alemtuzumab, trial of androgens, eltrombopag, and other clinical trials. And so it was seen that as 1/4 did not respond, around 40% responders relapsed, and 40% of unresponsive patients died within the next 5 years of diagnosis. There was a need to do something beyond immunosuppressive therapy and cyclosporin. And so if you look at this is a prototype study which they had done, and where they realized that eltrombopag could be a part of it. So this was a 16-year-old with aplastic anemia. She did not have a matched sibling donor. She was started on horse ATG and cyclosporin. She received 4 days of horse ATG, 6 months of cyclosporin. There was a complete count recovery. The child had responded. But 3 months later relapsed. Now what were the options? So they reintroduced cyclosporin. Quite a few of them respond to reintroduction of cyclosporin, but this girl did not. So the transplant workup was initiated, but there was no good donor for her. There was no sibling donor. She was given another trial with rabbit ATG and cyclosporin, and eltrombopag was commenced. What was seen is that there was a recovery of blood count in approximately 50% of the patients with cyclosporin, and this response was increased. The robustness was increased by adding eltrombopag along with cyclosporin. So that's how the eltrombopag use for refractory severe aplastic anemia came into place, and that's how it got approved for this indication in those who had not responded to 2 courses of ATG and cyclosporin. And what was found that there was a 50% response rate. And eltrombopag, after giving for a long duration of around 3 to 6 months, it could be stopped because of the good response. And those who had relapsed, they were salvaged by restarting eltrombopag. So that's how in refractory severe aplastic anemia, it was seen that there was a 40% response rate in the form of tri and bilineage responses. Patients had become transfusion independent and there were no new adverse effects reported. And that's how it is currently the only thrombopoietin receptor analog which is indicated for refractory severe aplastic anemia. So in summary, if a person has received 2 courses of ATG and cyclosporin, not responded, not suitable for a transplant, can be started on eltrombopag. And this eltrombopag gives a 40% response rate in those who have been completely refractory to all of the modalities. And this was a good thing for people who were helpless and at the end of nothing at the time of response. Now, how do these things act, and why do you think was eltrombopag? People were intrigued as to how eltrombopag is helping these people who are not responding to ATG cyclosporin. So what ATG does is it lyses the lymphocytes, and cyclosporin blocks the T cell function. So what does eltrombopag do? Eltrombopag basically acts on the hemopoietic progenitor cells and it stimulates them, and that's how it causes a trilineage response. So what does eltrombopag do? So then it was thought that if eltrombopag can be used in refractory settings, how can we improve the outcome in the first line severe aplastic anemia settings who have not received any therapy as of now? And that's where the rationale for starting eltrombopag in the first line severe aplastic anemia management was also started. So what was seen is that if you look at the bell curve, increased number of stem cells, the patient had a greater probability of recovery. Decreased number of stem cells, the patient had a decreased probability of failure to immunosuppressive therapy. And that's where what eltrombopag does. Eltrombopag increases the number of stem cells, and that's how it helps in increasing the recovery. So it was decided that if a person is failing to immunosuppressive therapy is because the patient has decreased number of stem cells. So by adding eltrombopag, they will be able to increase the number of stem cells and hence the chances of probability of recovery in these patients. Now, how does eltrombopag act? Eltrombopag is a thrombopoietin receptor agonist. And what does it do? It acts on the transmembrane domain of the receptor, whereas thrombopoietin per se acts at a different level. So they don't antagonize each other's actions, rather they work in synergism. And that's how they proliferate, differentiate the megakaryocytes from the bone marrow. And that's how they help in increasing and enhancing the stem cells and the progenitor cells in the marrow. And we know that when increased progenitor cells, our chances of immunosuppressive therapy also working is better. So that's how eltrombopag therapy is basically helping these patients who are otherwise not responding to immunosuppressive therapy. So NIH did a study from 2012 till 2018 over a period of 6 years. It was a phase 1-2 study. They added to horse ATG and cyclosporin eltrombopag to begin with. And this was an experimental study. It was done on a cohort of 92 patients, people who had Fanconi's anemia, severe liver impairment, or a clonal myeloid disorder on the testing. Before 12 weeks were excluded from the study. And eltrombopag, the patient cohort was started. The patient enrollment was, the patient had to be 2 years or older to get into the study. So patient and the dose of Eltrombopag was decided according to the age of the child. So if the child was 2 to 5 years old, the Eltrombopag was 2.5 mg per kg. If the child was between 6 to 11 years, it was 75 milligram. And anybody 12 years or older, whatever age, was given 150 milligram daily of Eltrombopag. And they divided the cohort into 3 groups. So the first group was they started with horse ATG and cyclosporin. In the first cohort, they added Eltrombopag on day 14 and continued it for 6 months. In the second cohort, they started Eltrombopag on day 14 but gave it only up to 3 months. And it was the third cohort whom they started Eltrombopag right on day 1 up to 6 months. So along with horse ATG and cyclosporin, they started with the Eltrombopag. Now, what they labeled as complete response was to get an absolute neutrophil count of 1000, a hemoglobin of 10, and a platelet of 1 lakh. Any criteria, the counts not meeting these criteria were labeled as partial response. What the study, the age distribution, maximum number of patients fell into the 18 to 64-year age group being 66%. Less than 18 the contribution was, the number of patients was around 21%, and more than 65 years was 13%. And if you look at the results of this study, if you look at the hematological response at 3 months and 6 months, what was fascinating was the cohort 3, whom Eltrombopag was started on day 1 along with the immunosuppressive therapy and continued for 6 months. The overall response was 94%, which was quite remarkable, and a complete response of 58%. As we had seen in the previous studies where they had given just immunosuppressive therapy with cyclosporin, the overall response was 60 to 70% with a complete response of only 10%. So there was a huge jump from 10% to 58%. So this was a big achievement that was there, and this was something which was a game-changing thing for patients with aplastic anemia who otherwise feel helpless and hopeless coming repeatedly for blood transfusion or platelet transfusion to the hospital. So this was a great achievement for children and adults of this disease. If you look at the overall survival censored for transplant, it was 99%, and not censored 97%, which was a great achievement in this patient population. Now, looking at the further effects of Eltrombopag on hematopoiesis, the cellularity had also a significant effect. The cellularity at baseline showed a p at 3 months and at 6 months. The p-value was significant. So there was a significant increase in the cellularity due to Eltrombopag. So was with the CD4 cell count. That means the precursor stem cell count had also increased, and that's why the patient had responded to addition of Eltrombopag. This is the same thing where we said that the overall survival was very good, more than 95%. Now, next thing was cyclosporin, how long to maintain. So what they observed is that those who had stopped cyclosporin at 6 months after therapy, 32% responded, 32% relapsed. So they added on continued cyclosporin at low doses for another 18 months, so a total of 2 years. And the relapse rate was just 14% compared to 54% when cyclosporin was stopped at 6 months. And what they saw is that only by adding cyclosporin, 52% could again go get back their counts, but around another 40% required Eltrombopag to be added. So that is subjective variation whether you want to add just cyclosporin or you want to continue Eltrombopag along with cyclosporin to achieve the response. So it was seen that there is cohort 3, where we had given Eltrombopag for 6 months. The relapse-free survival was around 83.1%, but they needed to continue low-dose cyclosporin for a total period of 2 years. So now next was whether does Eltrombopag cause clonal evolution? By causing clonal evolution, are we subjecting the person to have conditions like myelodysplastic, AML? Are we pushing for a second malignancy for these patients by adding Eltrombopag, by stimulating the stem cells? That was a worry. So it was that point was also looked at in the NIH study, and it was found that there was no great increase of clonal evolution incidence. It stayed around 8% even without L-Thrombopag, and even with L-Thrombopag in the patients who had received L-Thrombopag right from day one and who had not received immunosuppressive therapy. So the first time patients who had received immunosuppressive therapy with L-Thrombopag, there was no change in the clonal evolution, and it stayed the same. So it did not give rise to increased clonal evolution or evidence of second malignancies in these patients. Now, if we look at the safety data of L-Thrombopag in these people, the safety data is also at par. There are no major side effects. In adults, it was seen that there were liver transaminases which had increased marginally in around 25%. Febrile neutropenia and serum sickness was the second major complication seen in these, but this could be overcome. This was depending on the dose adjustments that this could be taken care of. Even in children, the commonest thing that was seen was the liver derangement, the increase in the serum transaminases, which was around seen in 23%. Children had more episodes of febrile neutropenia compared to adults, seen in around 24%. But this could be tackled, and there were no major side effects because of this. So if I summarize my talk, that if we have a child or an adult with aplastic anemia who has acquired aplastic anemia, and we've ruled out that there is no congenital aplastic anemia, what we need to do is first is control the infection and give transfusions. After that, we work up the child, whether the child is suitable for a transplant or not, has a matched sibling donor, and we subject the child to an allogenic bone marrow transplantation. If not, then we consider immunosuppressive therapy. As I said, the robustness of the response in children with just immunosuppressive therapy is also good enough. So we may or we may not add L-Thrombopag depending on the financial status of the child. We evaluate the child at the end of 3 to 6 months. And if there is a treatment failure, either we subject him to an alternative donor transplant, which has a lot of varieties, matched, unrelated, umbilical cord transplants. In adults, if we have a transplant availability, we go ahead with a transplant. But if we are giving immunosuppressive therapy, L-Thrombopag is, along with immunosuppressive therapy, is known to work better. And we can look at the response at 6 months, and depend if there is a treatment failure, either we give a second course or we subject the patient to an unrelated transplant. So to conclude, supportive care is essential. L-Thrombopag definitely induces a tri-lineage hematological response, and it has been considered as the first-line treatment option along with immunosuppressive therapy. It is now approved in India. It has the maximum impact if started on day one, along with the immunosuppressive therapy, and look at the response at the end of 6 months. The overall response has been around 94% with a complete response of 56%. The safety profile is quite okay, as it has been used in other conditions like chronic ITP, HCV. There are no major side effects with L-Thrombopag. So at the end, I would like to thank Novartis for sponsoring, and thank you very much.
Thank you very much, Madam Preeti.
Yeah.
There's only one question in the question box. What is the cost of L-Thrombopag?
Yeah, so L-Thrombopag is a little expensive drug, to be honest. A strip of 7 causes around 7,000. The price varies from company to company, but usually somewhere around between 4,500 to 7,000. So that is the response that in children, we don't want to use it unless they are affording it, because anyways, we see robust responses, but in adults, if possible, it's better to use it.
Any other question from the panelists? Thank you very much, Dr. Preeti Madam, and it was a really wonderful lecture.
So much, sir.
Now we move on to the next speaker, and the next speaker is Dr. Tapaiwala and Dr. Shruti Tapaiwala. She is a consultant at the Department of Nephrology, Sir H.N. Reliance Foundation Hospital and Research Center. She completed her MD Internal Medicine from Nair Hospital and TN Medical College, followed by DNB in Nephrology at PD Hinduja Hospital. She then completed Fellowship in Nephrology, University of Health Network, North America, Fellowship from American Society of Transplantation, and Fellowship in HLA Medicine and Advanced Transplant Diagnostics. She has a rich experience in the management of solid organ like kidney, pancreas, heart, lung, and liver transplantation patients at the multi-organ transplant unit, University Health Network, Toronto, Canada. She has been instrumental in initiating living donor paired kidney exchange transplant and ABO incompatible kidney transplant at Kokilab and Dhirubhai Ambani Hospital. She has been an invited faculty for several national as well as international conferences. She has many peer-reviewed publications to her credit. She established the first robot assistant renal transplant program at Sir H.N. Reliance Foundation Hospital, Mumbai. Today, Dr. Tapaiwala will be talking to us on HIV and kidney. Over to Dr. Shruti Tapaiwala.
Thank you, everyone. Thank you for that kind introduction. I will just try to share the screen. So let me start. HIV and kidney. It is a difficult thing to think about because when we hear about an HIV infection, we feel bad. That is the first feeling we get, that you know what the patient must be like, how badly infected the patient must be. It is HIV. What can we do? So all this was the past. Now what has happened in the last, when I was a student, I realized that the HIV infections were just starting and we were scared of the infection. We would be scared of going near the patient. You get nightmares that we have been infected because we got a prick or something. But now things are so streamlined that we have learned to live with the HIV infection. We've learned to treat it. We have learned to take care of patients. We have also learned to give them the same dignity and the same care which we give to other patients. So let me start with the case which I just recently saw in October at Sir H.N. Reliance Foundation Hospital along with the gastroenterology team. So this is a 32-year-old female who presented with severe cachexia to the GI department. She was admitted, and on a routine triple H test, which is done for the patient when the patient is going for procedures, as soon as she was admitted, she was found to be seropositive. And she had a cirrhotic liver disease. She was referred to me for a renal dysfunction and hyponatremia with anasalga. So see, I have just put a snapshot of my first note which I have put when I saw the patient. And here the main issues were that she had a 1 month of illness. The relatives said that we don't know, she stopped eating, she's been going downhill. She had history of abortions in the past, no blood pressure, no diabetes, nothing. And she had no alternative medicines, just that she was unable to eat and she had lost a lot of weight. On admission, there was found to have been an abdominal pain and swelling. Her urine routine had pyuria. There was leukocyte esterase, which was positive. There was hematuria. There was no proteinuria. So there was severe hypoalbuminemia. She had an albumin of had severe anemia, which was investigations when I saw her, and the PS for schistocytes was negative and reticulocytosis was positive. She had a deranged coagulation profile where the INR was more than 2. She had acidosis with a serum creat of 1.4. Now, mind you, she had lost a lot of muscle weight. Her weight was only 28. So, with that, this creatinine was high. She was severely intravascularly dehydrated. Her IVC screen was showing that it was collapsing with respiration, but she was third spacing. She was edematous all over. Her sonography, which was done on admission, revealed multiple liver lesions looking like abscesses, and kidneys were normal size and looking normal. She had pitting edema. Her abdomen was soft, distended, but there was no rigidity or tenderness. She was conscious oriented. But she was skin and bones. You could literally see the malnutrition and the cachexia. So at that point of time, I had given them a diagnosis of an acute kidney injury because of intravascular dehydration, pre-renal factors, because of severe hypoalbuminemia. What happened to the patient afterwards? She was found to have a B-cell lymphoma. The liver lesions were biopsied and she was found to have a B-cell lymphoma. She had a very high viral load also. We involved our ID specialist and he said that because there's a she has a lymphoma and she has a kidney injury, we may not be able to start heart at the same time, but our oncologist started a little bit of steroid so that the lymphoma is taken care of. She also had an SBP during the admission with lactic acidosis, DIC thrombocytopenia, and raised INR. First 15 days, she seemed to be having improved, but later on, she succumbed to a lot of resistant infections. So this was a case where, she came at a very late stage where, she must have been in an AIDS complex with lymphoma around, high viral load, the CD4 counts were very low. But, this should not happen in today's world. So let us discuss today how are the ways that HIV can affect the kidney. AKI in HIV, acute kidney injury in HIV infections, medications and renal affection, how can we adjust it? Chronic kidney disease with HIV, how do we treat it? And lastly, end-stage kidney disease with HIV, how do we manage and how do we give our best to the patients and what are the outcomes? So the prevalence of renal disease in European cohort is 0.31 to 0.5. US cohort is 3 to 8 per 1,000 patient years. Burden of renal disease expected to increase as the HIV infected population is now surviving better because of the various treatments which are available. It is often combined with diabetes, blood pressure, and hepatitis C. There is a genetic correlation wherein an HIV infection is more common with a deranged sugar. Hepatitis C is just a co-infection, and hypertension because of the renal involvement. Acute kidney injury and CKD is more likely in HIV than in non-HIV as per literature. AKI, HIV related renal failure includes AIDS defining illnesses, with a very high viral load, or the use of indinavir, tenofovir, or nevirapine. CKD, HIV related renal failure having a high viral load and a lower CD4, use of tenofovir and indinavir. Immune activation occurs, inflammatory cascades and IgG or Ig complex deposition. Some interleukins enhance the viral replication. So these are very important factors in which the kidney gets affected in the sidelines. So what are the reasons of acute kidney injury which we are seeing? So like I told you, I recently saw this case and she had anything and everything to do with all the multifactorial causes which can cause an acute kidney injury. Pre-renal states, hypovolemia, cirrhosis. Our patient had cirrhotic liver disease, she was hypovolemic. Acute tubular necrosis, ischemic, sepsis, IV contrast, nephrotoxic medications. Now, many of the HIV patients will have cancers, they will have multiple infections, and they will receive contrast for CT scans because you need to identify what are the lesions. So these are all the risk factors which increase their chances of getting an acute kidney injury. They are on medications which can potentially become nephrotoxic because of the pre-renal states, because of the diuretics they may be on, because of the multiple nephrotoxic medicines they are on together. Post-renal causes nephrolithiasis. Now, why nephrolithiasis here? Because these people are on medications which can cause crystal precipitation and it can cause stones made of crystals. They are dehydrated. They can be more prone to have renal stones. They can have cancers. With cancers, you can see tumor lysis syndromes, which can cause acute kidney injuries. Infections like pyelonephritis, there can be abdominal SBPs, there can be tuberculosis, there can be PCP infections, there can be so many things which are adversely affecting the kidney. Interstitial nephritis, again because of medications, and HIV associated thrombotic microangiopathy. These all go in the category of acute kidney injuries. What are the outcomes? So inpatient mortality is significantly higher. Like in our patient, the patient succumbed after around 25 to 30 days of admission. She was an inpatient, she had infections, she had AKI, and she succumbed to it. So it is significantly higher among HIV infected patients with AKI compared to those without AKI. So if an HIV patient is admitted just for some other reasons and there is no AKI, the mortality is low. Long-term mortality is higher amongst HIV infected individuals with AKI. So all these literatures where there is an average follow-up of 5 to 5.7 years after discharge, they have found that the mortality in people who had AKI, inpatient mortality and the long-term mortality is high. End-stage kidney disease and cardiovascular events are also very common in HIV-infected patients with AKI because remember, AKI means that your renal function is deranged. When your renal function is deranged, you are retaining high molecular weight toxins and middle molecular weight toxins, which the kidney or the dialysis is not able to remove. I can do a SLED, I can do a CRRT, I can do a normal dialysis for a patient, but it is not going to remove the microalbumins. It is not going to remove all the big toxic materials which are of a higher molecular weight. A kidney function and a dialysis can never be equated. Now, what about medication toxicity? Because whenever someone sees a HIV patient or a patient who has multiple medications, the toxicity is the first thing which come in mind. So, what are the mechanisms in which these medications which we use for HIV work, and how do they damage? So, you have integrase inhibitors which are working in the cellular DNA. You have a reverse transcriptase inhibitors which are working in the nucleus of the cell. There are fusion entry inhibitors which are working on the cell surface. There are protease inhibitors and maturity inhibitors. These are the type of targets of the antiretroviral drugs which we see. What are the toxicities we see commonly? We see antiretroviral related toxicities, indinavir, azanavir, and tenofovir. Now, why do these cause toxicities? Because these are going to cause crystal nephropathy. So these crystals will precipitate in the tubules and form microlithiasis sort of a situation wherein you will have a acute kidney injury or a post-renal kind of a kidney injury. So what would be the best to do when these people are on heart? We would like to hydrate the patient well. We would like to alkalinize the urine properly so that the crystals don't form. Other antivirals which we commonly use, acyclovir, foscarnate, these also cause injury. Now, mind you, all these things can cause interstitial nephritis also, allergic interstitial nephritis also. All these things can cause this also in addition to the common mechanism. Other antibiotics like Septran. So, Septran is known to cause a lot of electrolyte disturbances. It is supposed to decrease the GFR by decreasing the secretion of creatinine in the tubules. So, this indirectly causes the creatinine to go up. Pentamidine and aminoglycosides. These will cause a direct nephrotoxicity. Antifungals like amphotericin, which may be commonly used in these patients when they are sick, can also cause a toxicity. How does ampho-B cause a toxicity? So there is a direct damage of the distal tubular membrane leading to wasting of the sodium, potassium and magnesium. There is a tubular glomerular feedback and further constriction of the arterioles. And because there is a constriction of the arterioles, there is a decrease in the GFR. So we have to understand that every drug given to every patient, be it an HIV or a non-HIV, we have to understand what it is going to do to the various organs inside. Now, heart. So, indinavir and azanavir can cause crystalluria and AKI, like I told you before. Tenofovir can cause AKI with or without proximal tubular dysfunction. It can cause a Fanconi syndrome. You know, you may not see a creatinine which is high, but you will see electrolyte disturbances, you will see glucoseuria, you will see amino acid urea. It can cause osteomalacia. So these are very important things. When you see, there can be acidosis. So there can be an RTA-like presentation. So, you know, these drugs used for HIV and the combinations which are used can cause multiple issues. A meta-analysis of 17 studies show that the drug safety significantly greater loss of kidney function with the TDF and 0.7% risk difference with 95% confidence interval, also demonstrated with diadenosine. So that means most of these hard drugs need to be monitored. So not that we should refrain from putting them on heart, because heart is very effective, but we need to monitor the patients. Other medications, so these patients are prone to have herpes. We will give acyclovir. They may have CMV. We may give cidofovir. So there can be a ATN with a crystalluria. There can be a nephrogenic DI where you will find a lot of hypernatremias, hyponatremias, electrolyte disturbances, proximal tubular damages. Anti-pseudomonal drugs. So many patients admitted to the hospital can have Pseudomonas, Klebsiella, Acinetobacter nowadays, and you might give trimethoprim sulfamethoxazole. So that is Septran, and it can cause acute interstitial nephritis. It can cause electrolyte disturbances, like I'll show you in the next few slides. Pentamidine, which is given for PCP prophylaxis or which is given for PCP pneumonias, will cause a nephrotoxic ATN in at least 25% of patients. So if you see these crystals, these are septran crystals in the urine, which are very characteristic. Now, what are the electrolyte disturbances and how are they caused? So this is very important. You may not find a creatinine which is high, but you may persistently find some electrolyte disturbances. So prior to heart, hyponatremia was the most common electrolyte disturbance in HIV because of volume depletion being the most common cause. SIADH, idiopathic related to lung infections and malignancies. Hyperkalemia is also very commonly seen in people who are on heart and on prophylaxis because pentamidine and septran cause a lot of hyperkalemia because the potassium excretion is inhibited. Electrolyte depletion due to tubular dysfunction associated with a number of agents used to treat HIV or infectious complications like tenofovir, foscarnet, amphotericin, pentamidine, hypophosphatemia, hypomagnesemia, hypocalcemia. These can be very, very severe and symptomatic. So if you see, there is a myriad of electrolyte disturbances which can be seen in these patients, and someone needs to clearly look at the medications, that what are the medications which are causing this, how can I replace it, what is the volume balance I need to achieve, so that volume related electrolyte disturbances and drug related disturbances are minimized. Now, what are the CKD causing HIV related issues which can affect the kidneys? One is the HIV associated nephropathy, which is HIVAN. Something known as immune complex GN, which is HIVIC. These are two commonly seen infections, few commonly seen in India, few commonly seen in African subcontinent, few commonly seen in American subcontinents. Hepatitis C is a common co-infection related with renal disease in HIV patients. So we should be checking for Hep B, Hep C and HIV simultaneously. Post-infectious GN, because they can have skin lesions, they can have upper respiratory tract infections, post-streptococcal GN, because these can have myriad of infections which can make an immune complex disease and a post-infectious GN. Membranous GN, membranoproliferative GN, IgA nephritis, lupus-like diseases, but the dsDNA may be negative, but the lupus screening ANA can come positive. Cryoglobulinic GM, secondary to hepatitis C. Thrombotic microangiopathy, which is commonly seen. Our patient had TMA, but it was secondary to DIC. There were no schistocytes in the blood. So, you can see a myriad of things, but you have to find out what is the cause and treat accordingly. Hypertensive nephrosclerosis, because these people may have a collapsing glomerulonephritis with a severe hypertension. And a diabetic nephropathy, because they are prone to get more diabetes. Now, what is the outcome of these things? So there are predictors of acute renal disease and end-stage kidney disease and renal death. So if the baseline GFR, so based on the baseline GFR, if your baseline GFR is good, then your mortality is low. Every 10 years of age increase when you're diagnosed to have these renal dysfunctions will increase the mortality. Lower CD4 count will give you a twofold higher mortality. Cardiovascular risk is higher if you have a renal insufficiency. If you have an HIV positive versus negative positive, obviously will have a higher mortality. If you have a prior AIDS and you have come out of it, you still have a higher risk of mortality. But as years go by, the mortality reduces. Now, what is the renal disease and HIV progression or AIDS death? In a cohort of 5,800 patients, years of follow-up, 22% were female, 34% African Americans, 38% on heart, and 3% had CKD on baseline. CKD at presentation was not independently associated with increased risk of AIDS defining illness or AIDS related death. So as years are going by, the perception that with renal failure we can manage better is improved. Now let us look at glomerular disease in the next 3-4 slides. So one is HIVAN, like I told you. One is HIVIC, which is an immune complex disease. And the third is thrombotic microangiopathy. So when you look at glomerular disease, you have to think of these three things when an HIV patient presents with a glomerulonephritis. So HIVAN, which is HIV associated nephropathy, closely associated with black race, still sometimes seen in Indian subcontinents. more so than any other cause of ESKD outside of sickle cell disease, leading to ESRD in young African American adults. Heart has decreased the percentage of HEVAN. Due to the increasing number of HIV infected patients, the annual incidence of HEVAN is increasing. First described in 1984 as a complication of AIDS, but then it was realized that it is more because of the virus, and with the control of the viral load, the incidence is reducing. So what is the pathogenesis? HIV virus in the renal cells. So in the murine model, HIV-1 expression in the renal epithelial cells necessary to development of HEVAN. Since the mice don't develop AIDS, show an independent of immunosuppression, suggested that the viral gene expression in the renal cells is important. So the viral RNA is going into the renal cells and adapting themselves. Also showed that HIV positive patients with HEVAN, HIV infected tubular and glomerular epithelial cells. So most of the cells in the kidney parenchyma will take up the virus. Unclear how it enters the epithelial cells, but the PCR suggests that CD4 and CXCR4 can be detected in the cultured renal epithelial cells. What is the pathology we usually see? Typically, it is a glomerular collapse. So it is a collapsing glomerulopathy with overlying epithelial cell crowding. So if you see, this is a collapse. So this is a glomerulus. This is the Bowman space, if you see. And you can usually, if you have a normal glomerulus, you will see a thin line of the Bowman space. But here, there is a collapse of the glomerular tuft, and you are seeing that there is a lot of cells in this overlying epithelial cell crowding and hypertrophy. So if you see this, there are two glomeruli which are trying to collapse. Okay. So what are the clinical features typically seen in a setting of a very high viral load? Rarely in acute HIV infections in the first few months, because it takes time for the virus to go into the renal parenchymal cells, establish themselves. Typically, a rapid decline in the renal function is seen because these are collapsing glomerulopathies and the filters die out very fast. There is significant nephrotic range proteinuria which is seen. So people will present with a nephrotic type of a syndrome. Typically, there will be a lack of peripheral edema, but there will be hypertension. Uric acid, urine analysis will typically be bland. So, and the sonographies will show echogenic but enlarged kidneys. Rather than shrunken kidneys, you will find enlarged kidneys, and the diagnosis requires a biopsy. So in an HIV patient, when in doubt, always do a biopsy so that it can be treated fast. Again, retroviral treatment, there are no RCTs, but observational studies have shown a benefit with the ART. Limited dosing options, because if you have a renal dysfunction, but you have to adjust and go ahead. The viral load reducing will reduce the HEVAN. Prior to ART, patients may progress to end-stage renal disease within 1 to 4 months of diagnosis, and no slower with ART. So this is a very bad diagnosis to have, but if caught up early, and if an HIV patient is diagnosed early and treated with heart, this complication will not happen. You will find a very low CD4 count. You will find elevated serum creatinine. You will find increased proteinuria. You will find a higher viral load, and you will find a Hep C co-infection. In general, worse renal survival compared to non-HEVAN. So HEVAN is a very bad prognosis to have because already the glomerulus is dying. Other treatment, obviously for the proteinuria, you can put them on ACE inhibitors. Again, renal function, potassium has to be seen. Steroids, no benefit because it is caused by the renal virus, the HIV virus in the renal cells. Dialysis or renal transplant remains an option, which I will discuss later. Now, thrombotic microangiopathy and HIV. So, multiple causes. TTP and adult HUS are considered to be a part of the spectrum of disease known as TMA because they have a similar histological characteristics, and these will be characterized by fever, neurological dysfunction, renal dysfunction, thrombocytopenia, peripheral smear showing schistocytes. It is rare in healthy people, and the mortality is more than 95% if it is left untreated. Treatment is usually with plasma exchange, which dramatically improves the prognosis, because if you have factors which are causing TMA and you remove them on plasma exchange, you will benefit. TMA is associated with bacterial toxins, immune complexes, autoimmune disorders, cancers, hemolysis syndromes, organ and marrow transplantation, drugs. Association of TMA with HIV was first recognized again in 1984. Both TTP and HUS have been reported in HIV infected patients. In our patients, we saw TMA, but it was more because of the DIC and not because of any of the drugs. Reports of prevalence of TMA in HIV infected patients varies from 1.4% in the pre-heart era to 7% in hospitalized patients with AIDS. In the chorus cohort of 6,000 patients, 0.3% had TMA. And these were all related to a lower CD4 count, higher HIV RNA levels, greater incidence of AIDS, greater incidence of Mycobacterium avium complex, greater incidence of HIV and death, HCV and death. Now, what about immune complex mediated GM? Now, this is like a situation where HIV virus can trigger off an immune response, and the immune complexes can deposit in the glomerular basement membranes and cause a glomerulonephritis. So, nearly 40% of HIV infected patients with a proteinuria kidney disease and suspected HIVAN will have another diagnosis on biopsy. So, not every HIV is going to have a HIVAN. You have to look at the profile, you have to look at the race, you have to look at the gender, and you have to decide that, okay, what can this be? But a biopsy is absolutely must so that you don't get a surprise that you are treating something and the diagnosis is something else. There can be membranous, there can be membranoproliferative, mesengoproliferative, lupus-like proliferative G, and rare cases of IgA, because any virus can incite an IgA. Natural history of these diseases in HIV and response to heart has not been well studied, but the treatment remains like we treat the non-HIV patients. And lupus-like diseases tend to be more aggressive, but these are more seen in African patients because they are more immunologically active in their genetic nature. Now, HIVIC, like I said, it is like a unique immunocomplex disease with characteristic ball in the cup basement membrane reaction, first described in South African biopsy series. Role of viral pathogens, antigens in circulating immune complexes and pathogenic relationship between HIV and development of HIVIC has not been studied. So here, HIV viruses have not been found in these cells. Now, co-infection with Hep C is very important. We have to study that because now we have Hep C related treatment too, because hepatitis C can again cause cryoglobulinemia. It can cause hypocomplementemia. It can cause so many myriad of diseases which may not be related to HIV. And the treatment might be plasma exchange, corticosteroid and antiviral therapy for Hep C, which is easy. Previously, we had to give interferons, which were very risky, which was reacting. But now we have safer drugs. Now, what about a patient who develops end-stage kidney disease? We know that AKI can be treated, that the acute illness will be treated and the AKI will resolve. We know that the glomerulonephritis needs to be diagnosed. But by and large, if you have diabetes, if you have Hep C, if you have HIVAN, if you have HIVIC, these will progress to end-stage kidney disease because you are not allowed to use a full dose of drugs. So many a times you have to start early so that you can protect the kidneys. Now, end-stage kidney disease means a GFR of less than 15%, and these kidneys are considered to be dead because less than 15%, your body is not going to be able to sustain because it will have severe hyperkalemia, fluid overload, it will have hypertension, it will have uremia, it will have acidosis. So less than 15% or 10%, we can consider that there is no renal function in the body. And there remain only two options, lifelong dialysis or transplantation. And essentially it boils down to either hemodialysis, peritoneal dialysis or renal transplantation. Now, all these things seem to be very difficult. They seem to just produce a doom saying that, oh, now what is to be done? Everything is under control, but the kidney has failed. Now with HIV, what are we going to do? How is this person going to live? But no, in today's world, we as a scientific community have progressed and these patients can live a better life if the HIV viral load has been under control and the CD4 count is good. With the heart therapy, with proper multidisciplinary care, with an infection control specialist, infection disease specialist, a nephrologist and a physician, everything can go well. So the two options of dialysis, let us see first. The hemodialysis, everyone knows this is a dialysis machine, a fistula, but it is not as easy as it looks, because for an HIV patient, I cannot have a dialysis done in a common area of the dialysis unit. I will have to have a separate unit, which means that one machine has to be earmarked only for an HIV patient. One technician has to be earmarked only for that HIV patient when he or she comes for dialysis. That technician and the nurse will have to be in full protective gear with universal precautions so that they do not contract the disease. So these all make hemodialysis extremely costly. So if someone wants to know the cost of a routine hemodialysis is around 1700 to 2000 rupees with the consumables per session. If you discard the dialyzer every time, it is 3500. But if you are an HIV patient and you are dialyzing yourself, everything is a use and throw. And everything is charged because it is a single use for everything. No other patient is affected. Your dialyzers will not be reused because you do not want to cross-infect anyone. So the HIV infected patient dialysis cost may go anywhere between 7,500 to 10,000 per session, which is extremely costly. So what is the next option I have? I have an option of PD, which is very cost effective. So a PD or a peritoneal dialysis done for a non-HIV patient or an HIV patient, the cost remains the same. So many a times when I have an HIV infected patient, I will refrain from putting him in the dialysis unit because he will spend a lot of money and waste money rather than being on PD. So what is PD? So we use the peritoneal membrane and the peritoneal cavity as the dialyzing area. So the peritoneal membrane acts as a filter and the peritoneal capillaries act as a osmotic layer. So these capillaries are full of toxins, they may be full of infections or whatever it is. And when you fill in the peritoneal cavity with fluid, which is a dialysis fluid, what will happen is all the toxins, because of the osmotic pressure and because of the diffusion concentration gradient, the toxins and the uremia and the acidosis and the electrolyte disturbances will be corrected without any need of blood, without any need of machines, without any need of needles being pricked. So this is a very safe method for an HIV patient to be dialyzed, keeping them stable, keeping them normal, because one, it is not hindering their life, one, it is cost effective, third, he or she does not need to travel again and again and expose themselves to the hospital environment. So how is it done? So it is simply 10 to 20 minutes process that you have to laparoscopically insert a PD catheter, which looks like this. It is below the umbilical level, so it is very safe and it is cosmetically also not very ugly. Once you have to start a session, whatever fluid, dialysis fluid we have filled inside the peritoneal membrane will have to be drained. So you open one clamp and it is drained, and this filled fluid or the clear fluid is clamped off at that time. Once it is drained, the clean dialysis fluid is put into the abdomen, 2 liters of it at a time, and there is a disconnection. So that means in 20 minutes, you have essentially removed all the dialyzed or the dialysate, and you put in fresh dialysis fluid into the peritoneal membrane, and the person is free to walk around, do his or her work for the next 4 to 6 hours. 3 or 4 such sessions in 24 hours is enough to keep a person normal. Okay, so this is one kind of dialysis which is very apt for a hepatitis C, hepatitis B, or an HIV infected patient because it is very cost effective. So what are the advantages of PD over HD? If I see in a normal situation, it is a continuous process. It mimics a normal kidney. A person can remain ambulatory, no dependence on machines. Hemoglobin levels are better maintained because you are not using blood. Residual renal function is also better maintained. So they will keep producing urine for a longer period of time than when they are on hemodialysis. The only disadvantage is that after 5 to 6 years, the peritoneal membrane will have adhesions. So you may not be able to use it and it will become thick, but that is 5 to 6 years down the line. You can use it immediately. Peritonitis, if the person is not hygienic and they are not trained well, then you can get peritonitis because your surface bacteria might go inside. But then with today's world, I am seeing lesser and lesser PD infections in my patients. Now the cost. When you look at dialysis, I told you that the hemodialysis cost is extremely high. And because hemodialysis or peritoneal dialysis is not going to be a complete therapy, what I can say, or a cure, it keeps giving you multiple admissions. Sometimes there is an infection, sometimes the fistula is failed, sometimes the HD catheter is infected, sometimes someone is getting an MI. So the cost keeps mounting. So in our team, what we do is that we first see that if the patient is stable enough, then the patient is given an option of transplantation before a dialysis starts. And I will give you some examples and our experience in the next 3-4 slides before we end the session. So what is the cost of transplantation for these patients? So 8 to 10 lakhs as a normal transplant. Immunosuppressive medications initially would be 10 to 15,000 a month. And of course, the heart medicines are continued and it decreases over time. So if you look at a stable HIV patient with a normal CD4 count and a good controlled viral load and has end-stage kidney disease, dialysis should not be an option, transplant should be an option. If there is no way you can do a transplant because you do not have a donor or the person is on a cadaver list, then dialysis is an option and PD can be a better option for you. This is how I have an algorithm for my HIV patient. Now let us see about transplantation, why we are saying that transplantation is good. Because there are international trials way back from 99 which have said that when you are on a waiting list for transplant and you do not get transplanted and remain on dialysis, you start dying faster. Whereas if you get transplanted, your life quality and survival improves. So this was a landmark article which told the world that dialysis is not a good option for end-stage kidney disease. Now, what is the success rate? And I'm talking about the HIV success rate also when I'm talking regards this. So the 1 year survival is 85 to 95%. 5 year survival is 85 to 95%. This is kidney and the patient. 10 year survival is 50 to 65%. So as nephrologists, we will suggest transplant because we know there's a better survival. We know there's a lower economic burden of the disease on the family and there is near normalcy of life. Now, there are multiple studies which suggest that the mortality in HD patients receiving ART, but kidney transplant recipients infected with HIV and receiving ART now have survival rates that are similar to uninfected allograft recipients. That means that in today's world, we are now near a non-HIV success rate. So I will be able to equate an HIV patient with a non-HIV patient when I am talking to the patient about success. Let me just end with 3 cases which we have transplanted in our group and just to tell you that how we can take people through. So in our experience in the last 2 years, we have transplanted 3 patients who have had HIV infections. All young patients, you see, Mrs. PH, who is a 32-year-old female, she was seropositive, hypertension, CKD. She had FSGS as a cause of her CKD. And she was advised RRT, renal replacement therapy, because she had end-stage kidney disease. Her viral load was good. Her CD4 count was normal. So we offered her a preemptive transplant. Her only donor was her mother, but then she was ABO incompatible. We went ahead with an ABO incompatible transplant in July 2016. Mind you, not even a normal transplant, an ABO incompatible transplant. And presently her creat, as of yesterday, I've just seen the records and the last creatinine within this month is 1.38. She's only on 5 milligrams of prednisolone and sirolimus as immunosuppression. Of course, she's on heart therapy. She's on all supportive therapy, but she's doing well, which is very important. The next patient, Mr. BJ, who is a 46-year-old male, he had end-stage kidney disease with a seropositive status with chronic tubulointerstitial disease. So it must be a drug-induced interstitial nephritis, which led him to have end-stage kidney disease, hypertensive since 4 years. We had put him on peritoneal dialysis since Jan 2019 because that time immediately we did not have a donor. He continued on peritoneal dialysis and underwent a living donor renal transplant in December 2019. Present creatinine is 1.04. Here again the donor was mother. Miss DC, whom we have recently transplanted in the COVID times. In June 2020, we have transplanted her. She's a young girl who is infected and seropositive, hypertensive since 1 year, CKD because of chronic tubular interstitial disease, which was diagnosed 5.5 years ago, progressed to ESKD. She underwent a preemptive, no dialysis, direct transplant in June 2020 from a donor who was HIV positive, and the donor is her father. So the whole family somehow had HIV positive status. Father donated to the daughter. So HIV donor has donated to an HIV positive daughter, and she's doing well. Her creat is pointed. So to summarize, renal involvement is very common in HIV infection because of multifactorial reasons. There are varied presentations and tailored treatment is required. A multidisciplinary care is required. If picked up early, we can prevent complications leading to AIDS-related cancers. HIV infected patients with ESKD can now be given an equal opportunity for transplant as given to non-HIV patients. Thank you. I end over there.
Thank you, Dr. Shruti, for wonderful presentation. I think Dr. Shruti has explained very nicely kidney disease in case of HIV patients. She has also told us about various ways of treating these patients and especially stressed on the role of ambulatory peritoneal dialysis, which is a very good technique actually, and very, very physiological way of doing the renal function. So thank you very much, Dr. Shruti. And if there are any question and answer, I will see. One question is, tenofovir-induced renal toxicity, is it reversible? And what is the upper limit of creatinine in HIV patients on tenofovir?
Upper level of creatinine, so we have to look at the GFR. So if we are putting someone on tenofovir, then I will need a GFR of at least more than 25 to 30 mils per minute, so that I know that I'm not damaging the tubules. And yes, tenofovir will be reversible if we are hydrating them, alkalinizing the urine, and using a dose-adjusted dose of tenofovir.
So that was a question from Dr. Narendra Kumar, and now the question is from Dr. Rajan Patel, and even I wanted to ask this question. If peritoneal dialysis is so physiological, it has so many advantages, why still hemodialysis is more popular?
So I will tell you, every country has its own pathology, I would say, in thinking. So say I have worked a lot in Canada, and I have seen the US side also, because we would go for cross-reacting with their fellows and things. And we realized that Canada, Australia uses a lot of peritoneal dialysis even for normal population, because it is a non-insurance based government universal care. So what happens is that the government wants the people to be independent. They do not want people to be dependent on hospital care, because nursing is extremely costly. And patients have that attitude of being self-reliant. They do not want to be dependent on a hospital or a nurse. That is a very important factor which I have seen. America, what happens? Patients are lazy. People are lazy. It is a medical insurance guided healthcare. Doctors are paid per dialysis session when they are on hemodialysis. Peritoneal dialysis is not included in the medical insurance system and billed to the doctors. So what happens is that revenue and the attitude of the patients and the doctors guides the care. In India, what happens? I have seen it is a very good technique. People who do it wonderfully. But what do patients say? अरे मैं मेरा काम खुद क्यों करूँ? नर्स किसके लिए है? मैं उधर जाके लेट जाऊंगा, वो मेरा काम करेगा. This is one reason I get. Second reason I get is that they say मुझे घर को hospital नहीं बनाना. They don't realize it's not like making a hospital at home. It's just a corner of your house which you're using for your own care. That attitude change has to happen. I had an 82-year-old lady when I was practicing at Kokilaben, a doctor's mother. She carried the PD for 5 years on her own. She said, I will not come to the hospital. You tell me a technique which will not make me feel like I am dialyzing myself. Naito, I will not do anything. So it is just a matter of attitude. And if I explain to my patients well, they accept. It is on you and me how we put it to the patient. And sometimes what happens is we do not get adequate support or home care that we can troubleshoot the patients. That is also one of the reasons why PD is less popular. Previously, if you think of 10-15 years ago, we had a lot of PD coordinators in the population, wherein, Baxter, J. Mitra, Fresenius, and Claris, these are the 4 companies who provide PD materials in the world. They had coordinators placed in every city. So they would go to patient's house, visit, evaluate the patient, and call the nephrologist. We would troubleshoot. Now that population of coordinators has come down for whatever reason. So the doctor feels that, I have to take a lot of responsibility of the patient because patient ko kuch bhi hua wo mujhe phone kare. So what I do is I fix up a coordinator first whom I know is going to be nicely taking care of the patient. And I make a good rapport with them so that it's a closed loop and the patient does well. So I've got many patients on PD who are doing well because you have to make the patient self-reliant. You have to train them well. You have to make them understand that ये बराबर नहीं चला तो तुमको hospital में रोज आना पड़ेगा. Is it okay? And now in COVID times, so this is a boon.
So thank you, Dr. Shruti, for wonderful presentation once again. And now I hand it over to Dr. Anil Awad to take it further.
Thank you, sir. We have a very short presentation coming up with Mr. Dipen Mehta, who is the COO of DigiShield, and he's going to enlighten on digitalizing medical records and teleconsulting consent form. Dipen, please start.
Thank you, doctors. Thank you, IMA Mumbai branch. I think this is the 5th webinar which DigiShield is managing with the IMA Mumbai branch. And we have received a good response from the doctors, delegates, and from the organizing team of IMA Mumbai. I will not take you much time about having the digitalization. In current DigiShield is a software, AI-based software, which helps a doctor to make their prescription into digitalization. In India, we have seen more than 80% of the doctors are not using any software or not using any application to have their prescription into digitalizing. And if we compare to the foreign countries, most of the foreign countries are having more than 95% into digitalization. So there are a lack of challenges for Indian doctors who are facing and which have difficulty in making their prescription into digitalization. Also in current COVID situation, at least doctor has started the teleconsultation through some of the medium. But in India, the major challenge is with the doctor is the technology. So it has difficult for the doctors to adopt the new technology and to start digitalizing. There are various complex methods and complex softwares which face doctors difficult to have their prescription into digitalization. So DigiShield can help doctors to digitize their prescription very easy and very quickly. Doctors just need to download their application from Android as all iOS App Store. They need to have one-time registration of the patient. Once the patient is registered, they are good to go for digitalizing their prescription. Doctors can even do in India. You can see more than 80% of the doctors are not using digitalizing, and if we compare to foreign countries, there are more than 95% into digitalization. In India, the reason is the doctors are not into digitalization. Is the major challenge they are facing is the cost, capital investment. Thus, another major challenge is awareness, and the third challenge is about the procedure or the complexity of using the digital platform. So, DigiShield have developed the AI-based solution in which doctor can have their prescription into digitalization and very easy and quick way. Doctor has to just register the patient for the one time. Once the patient is registered, they can upload their prescription. They can upload the patient's medical records, patient's previous history, everything can be recorded in the one go. They just need to click the photo and upload. Patient will receive the soft copy of the prescription. Even patient doesn't need to have smartphone. Or a simple web browser can be work for the patients. If patients having some simple web browser phone, say as a Reliance, which is having like 1500 phone, even that will work for the patient. Patient just need to click on the link and they can view their prescription. Even in currently, because of COVID, many doctors are doing the teleconsultation or video consultation through WhatsApp or some other communication. But there is a risk for the doctor of the receiving the consulting fees. What if doctor has done a video consultation through WhatsApp and send the prescription through the WhatsApp? But through DigiShield, if doctor has done a consultation through DigiShield and shares the prescription to the patient, but patient will not be able to open or view the prescription unless and until the consultation fees has been paid. So if suppose a patient clicks on the link for the prescription, it will show a message or a pop-up message to the patient. Your so and so consulting fees is pending. Please click here to pay the consulting fees. So unless and until patient pays the consulting fees, then only patient will able to view the prescription. So it is safe for the doctor as well. And now nowadays, many of the video consultation or through WhatsApp, doctor find it difficult even to have their previous medical records as well. So through DigiShield, doctor can view the entire medical record, entire previous history of the patient's, number of times the patient has been visited. And the software is totally free for the doctors. It's free for the lifetime. It's not that only for current COVID period or like for 6 months or 12 months we are giving free. We are giving the software free for the doctors for the lifetime. So would recommend doctors to start downloading the software from the Android or iOS App Store and start using it. If you have any queries, any issues, you can always contact us. You can always reach us. If you want, we can we'll share the link of the downloadable to your SMS. If you have any queries, you can reach us at www.digishield.me. And if you have any queries, question, you can also send your question in Q&A session. Thank you. Over to Dr. Anil.
Yeah, thank you very much, Mr. Dipen. It is always nice listening to you, and many things are coming up about the teleconsultation and all the other things. Now we go on to the session proper, and now the next speaker is Dr. Paresh Jain. I request Dr. Girish Rajadhyaksha sir, the chairman of World AIDS Day, to introduce Dr. Paresh Jain. Okay, I'll introduce Dr. Paresh Jain. Dr. Paresh Jain is a consultant laparoscopic and robotic colorectal surgeon at Sir H.N. Reliance Foundation Hospital and Research Center. After having completed his MBBS and MS General Surgery, he pursued his MRCS from Edinburgh. He then completed fellowship in colorectal surgery from the Royal College of Surgeons, Edinburgh. He has also obtained training in diagnostic therapeutic colonoscopy procedures from North Wales, UK. He has published many articles in peer-reviewed journals and written chapters in various textbooks. He has special interest in minimal access intestinal surgery for cancer and benign colorectal conditions, advanced surgery for piles, fissures, and fistulas, including Doppler-guided surgery, and treatment for benign pelvic floor disorders and incontinence. He is also a trained robotic colorectal surgeon for benign and cancer cases. Today, Dr. Paresh Jain will be talking to us on scar to scarless colorectal surgery. Over to Dr. Paresh Jain.
Yeah, good afternoon, good morning, and thank everyone. Firstly, I would like to thank you, the association, for giving me this opportunity to share my thoughts on how things have evolved in colorectal surgery, starting from a scarred abdomen to a scarless abdomen. Hopefully by the end of the presentation, I will be convincing most of the people that this is what colorectal surgery has evolved from about a couple of decades as it was before. So few of the points which we would like to discuss. Why colorectal surgery? I mean, we all have been trained into general surgery, GI surgery, and then why colorectal surgery nowadays is coming as a super specialty? the changing trends in how we approach to the cancer patients, what has evolved in that point, the various approach to enter the abdomen, that is laparoscopic, robotic, and now the natural orifice. And on a practical ground, what are the things which is actually available in India? We have read a lot in the book, but now what is really available on the practical ground in India? Probably these are the few things we'll discuss as we move down. So the changing trends in approach towards cancer patients, multidisciplinary tumor board. This is something which has got a revolution in management of cancer patients. We have changed from one-man show, like why I feel this is the right technique or why I feel that is the right approach. It has changed to our approach. It's a multidisciplinary team approach which involves the surgeons, the surgical oncologist, the medical oncologist, the radiation oncologist, pathologist, and the radiologist. So five-member team. Minimal access surgery, this has definitely taken a big leap, moving from open to lap and robotic surgery. ERAS is an important component which has helped early recovery and return to normal activity. It's enhanced recovery after surgery. And last but not the least, it's evidence-based practice. We never use the word my gut feeling says this. It's basically an evidence-based practice, and there is evidence to whatever we practice. So a couple of slides on statistics. Colorectal cancer is the third most common cancer in men and second most common cancer in women. If you see the statistics of it, I don't want to count how many of us have logged in, but the incidence of colon cancer is 1 in 19. So probably it's time we look into the screening protocol.
So coming to the statistics, this is the Globocon data published in 2012, and according to this data, if you see the blue line, the difference between the blue line and the red line, the blue line is line of incidence and the red line is the of mortality. Now, higher up on the graph, if you see the difference is too big, in which case the mortality is significantly low. However, if you move, as you move down the line, down the graph, sorry, the difference is too small, it's too narrow. And that's where we want to make a difference, where we can decrease the mortality rate by catching the disease early. We may not be able to prevent it, but at least if we catch it early, definitely we're going to make a difference. This is where one step the cancer has changed their approach. Rather than preventing the disease, we always look for prevention, but this here, we're basically looking for early catching rather than getting it late, thereby decreasing the mortality. So how surgically things have advanced in with regards to colorectal surgery. We'll talk about the laparoscopic, the robotic, even open surgery has evolved. There is nothing which has remained stationary in medical field. Open surgery itself has evolved from a vast, has changed a lot over the last decade. Natural orifice surgery, and then definitely ERAS is an important component of all the surgeries, be it lap, robotic, or open. So a couple of things on laparoscopic colorectal surgery. We all know the advantages of laparoscopic surgery. It's a keyhole surgery. Instead of getting a big 30-centimeter cut, we have 5 dots on the abdomen. The recovery definitely is early, much better than an open surgery. The pain level is less. And definitely, the most important point is the oncological safety. And only if it's oncological safe, it's recommended to offer. And again, there are enough studies to say when it comes to oncological clearance, the oncological survival or oncological disease-free survival is equal as compared to laparoscopic and open surgery. And that has been proven not by my study, his study, but by randomized, well-differentiated studies. And COLO2 trial, LOREC trial, and many more studies are coming through. So again, evidence to it saying that lap is better than an open surgery with early recovery. Through laparoscopy, you can offer all the kinds of surgeries of the colon, extending from the right colectomy to left, and then to total colectomy with a pouch formation for ulcerative colitis or FAP. So entire gamut of colon surgeries can be considered by a minimal access approach. This was one of my first cases when I came back to India from UK after my 7 years of training in UK. This was the first young lad, about 48-year-old boy, presented with rectal cancer and an ulcerative colitis background, and we did a total colectomy, proctocolectomy, and with a stoma, and with a pouch and a temporary stoma. If you see here, there are few scars on the left side. There are few scars and one fenestrial scar for removing the specimen, and then a temporary stoma which was reversed after 2 months. So again, he was kind of discharged day 5 after the surgery. after total proctocolectomy. Another advantage of a laparoscopic surgery, you see, this is the kind of specimen of the rectum and anal canal which comes out when you do a open surgery, especially in a male pelvis, which is more narrow pelvis. What happens is as we go lower down, the pelvis, there is quite significant narrowing at the level of the anal canal, and that's why what we call as a surgical waist. And this is where your chances are there that the margin may turn out to be positive if it's a very low rectal cancer. With laparoscopic surgery, your vision is much clear, and definitely this is what you get. You get it out as a cylinder rather than getting a waist, and that's why your margin positivity index has significantly gone down with laparoscopic surgery for rectal cancer especially. So then we moved on to the robotic surgery. Why only stop there? That's when the things evolved and came out the robotic surgery. And that's my friend Da Vinci robot at HN Hospital. Now, just in a brief nutshell about the various parts of the robot. This is the surgeon's console. So the three parts of the console: the surgeon console, the patient console, and the vision cart. The patient is on point B. Surgeon sits at distance A, and the most important part of the robot is the arms of the robot, which mimics your fingers. So proper 6-degree, and along with it, there's the 7th degree of motion which your arms cannot offer, your fingers cannot offer. That's the major difference between the robotic surgery and a laparoscopic surgery. In robotic surgery, the hinge joint or it's the wrist joint which is inside. In laparoscopic surgery, it is the elbow joint or the shoulder joint which works. So that gives more finesse, more finer dissection, and kind of a more time of a real-time surgery rather than a laparoscopic surgery which you're doing from a distance. A short video of how it actually works. Okay, so that's the surgeon console. That's the patient console. There's a 3D camera on which the head rests. What the fingers of the surgeon are doing is basically a master console. And basically when we move the fingers here, when the arms are moved, this is what the instrument will look like. This is how it moves. See the finesse with which moves. It takes care of the human, of 0.1 to 0.5% human error is also eliminated with the help of robotic surgery. And that's why dissection lowered on these arms are 0.8 mm, 8 millimeter arms. That's why, and as we go down further, they are about 0.3 millimeters. So the dissection is further finer. Excuse me. That's a 3D vision glass, and it gives you I'll show you on the next slide how the 3D actually looks like. And there you go. So basically, the important part of this is that it has to become with a team. You cannot be, it has to be a trained staff along with you who's operating. And the major advantage of the robotic surgery is pelvic dissection, where there is a narrow space, and the advantage of suturing, which we have seen over time. It started with the prostate surgery and now has moved on to the various gamuts of pelvic surgeries. And if you see the way we are suturing is as good as you're suturing in an open abdomen, but with more precision. So that's the major advantage of how the robot works. Yeah, so the advantages, it's the precision, 7 degree of motion, and obviously it's a 3D vision as if you're sitting inside the abdomen and operating. The disadvantage as of today is, since Da Vinci is the monopoly, there's only one company robot as of today available in the country. Cost is a little bit of a hindrance, I would say. It costs about $1.5 lakh extra as about an open surgery. And availability, yes, every institute is not kind of comfortable enough to maintain the robot. And fortunately, I'm in an institute which is supporting us well to go ahead with this robotic colorectal surgery program. And so we have a dedicated robotic colorectal program running in HN Hospital, wherein we have kind of everybody is enrolled into this robotic program. There's a bit of a training also happening, and we will slowly kind of taking it further, this program. Coming to the scientific data, there are enough scientific data to say that robotic surgery is working at par with the laparoscopic surgery. As of now, there is only one randomized trial which has come, the ROLAR trial, which says that the outcomes are equal as compared to robotic and laparoscopic surgery. but probably in the next 5 years, we're expecting more kind of studies coming up to show their advantages over the other approaches to the abdomen. This is the one of the few cases we did my robotic sigmoid colectomy in this 55-year-old gentleman, and that's my team. These are trained brothers and OT staffs to help us in the operation theater. And I have along with me my colleague Dr. Marzi Mehta as again a robotic thoracic surgeon who is at the patient side, who helped me with the robot and when I am on the surgeon's console. So as I said, it has to be a team approach. I cannot be alone with my friend. It has to be a total team who's trained into it, including the anesthetists led by Dr. Hemant Mehta, who help us coordinate with these cases. And that was the surgery, and he was actually discharged on day 4 after the surgery. A few vision of how the robotic surgery looks from inside. Now you've seen few laparoscopic images. This is the robotic surgery. And what we are just trying to show is the inferior mesenteric artery isolation and ligation. See the finesse, the clarity with which you can see the inferior mesenteric artery. And these are the arms of the robot, wherein you can see the way it cauterizes, it opens up the plane, and the bird beak appearance of these instruments gives it that finesse. These are 3 mm at the tip. The important part, if you see, is sorry, I don't do the surgery that fast. These are kind of customized, and I have fastened it. I've fast forwarded a little bit so that in the view of time. But what I want to see is these loose areolar tissues, which you will never see with an open eye, is visible only through this robotic 3-dimensional images, which are significantly magnified. The advantage, you can see the hypogastric plexus, the nerves around, thereby decreasing the risk of urethral syndrome and damage to the hypogastric plexus, thereby preventing the sexual dysfunction, which can happen after colorectal surgeries. And that's what we are holding is the inferior mesenteric pedicle and see the dissection. It's more clear now, very minimal blood loss, and yeah, and the approach. If you see, the approach is so much comfortable from the patient point of view as well as, sorry, from the surgeon's point of view, I would say, preferably. And that's what we can see is the ureter and the inferior mesenteric pedicle. I'll just show you another video. The importance in this video, I want to see the way I can hook around the inferior mesenteric pedicle. As if I'm putting an open instrument around it, I can clip it completely and transect it across. So that's the kind of the clarity and the, if you want to see in this image, these are the hypogastric plexus which is running down here. And I can see it with the robotic images, but with an open surgery, it's very like not really see encounter them, and there's high chance of damaging this hypogastric plexus down there, which you see it running from in the parallel to the screen on the inferior edge of the screen. So that's the major advantage of a robotic surgery, apart from definitely the advantage what a minimal access surgery gives us. So this is as a part of the ERAS, he starts eating within 24 hours, waiting rather than waiting for bowel movement or bowel cramps. Pain is utmost important part of ERAS. So pain, nutrition, and rehabilitation. They are the 3 most important components of ERAS. And if you follow them well, definitely you will be able to get an early recovery and early discharge, and ultimately early action to normal activity. So people must be thinking, if everything is the same, if oncological clarity is the same, oncological clearance is the same, recovery is faster, then why a robot? A small example, we all started with landline phone. We all had it in our house. In fact, quite a few still have it in the house. We moved on to an iPhone. But in the landline phone era, we still used to connect and things used to sail. But it's a matter of evolution. We wanted to be more comfortable. We wanted to give more comfort. We came up with a smartphone. But if you see today, about a year back, 2019, this is old age Nokia phone. It has come back into action. So nothing has gone off the market. Everything is still there available. It's just the comfort which you want to offer and the comfort which the patient would like to receive. That's why the entire gamut is still available. You still have a landline, you still have a basic phone, and as well as you have a smartphone available in the market. And all are doing well. That's why we need to know the entire gamut of approaches which are available and select which one is appropriate for the patient. So, as I said, the landline phone is still available. Open surgery is still an important part of the colorectal surgery. And we still do a lot of open surgeries. Not that I'm a robotic trained, I do only robotic, but open is definitely an important component and is offered to quite a few of our patients as well. However, even open surgery has evolved a lot over the last decade or so. When it comes to rectal resections, the initial margin they used to say has to be 5 centimeter distal margin, and majority of the patients with lower rectal cancer used to end up with a abdominoperineal resection and a permanent stoma. This has further gone down to 2 centimeters, and now 1 centimeter margin is enough. So we are further going down and down and trying to get back to natural passage rather than a permanent stomas. To the extent we have gone down to coloanal anastomosis, entire rectum and intersphincteric, wherein if the rectal cancer is involving the internal sphincter but not the external, you can do an intersphincteric rectal cancer surgery rather than, again, in about a decade back, the era was of abdominoperineal, where you end up with a permanent stoma. But here, you can still, if it's a young lad in his 40s, 50s, and sphincters are involved, the internal sphincter, you can still consider intersphincteric resection and get the anal canal, get the rectum down with a temporary stoma, not a permanent stoma. Cytoreductive surgery, this is which has evolved over last about a decade. Total peritonectomy and removal of the omentum. HIPEC is unfortunately not much picked up for a colorectal surgery, with a ColoPEC trial coming from France, which is a more of a negative trial. But again, case selection was a bias. Very selected cases may need a HIPEC in colorectal, not a majority, but though. Synchronous liver and colon surgery, metastatic colorectal resections. Patients with colorectal cancers with liver met initially were labeled as stage 4 and were excluded from the curative intent. Now we have something called as the palliative proper curative intent, with the intent of removing the rectum and or the colon and the liver in the same sitting. So in a tertiary care, quaternary care center, I would say, where we have a dedicated liver team, we have a dedicated colorectal team, we can do these surgeries at one sitting and benefit the patient rather than giving them two operations. Another is neoadjuvant chemo. The neoadjuvant chemotherapy has evolved big time. With the targeted therapies available, even metastatic lesions melt out with targeted therapy, and they come into the surgical realms, and then they offer definitive care. Targeted therapy, as we discussed. So just a couple of slides on cytoreductive surgery. And this is what we do for patients with extensive peritoneal disease with colorectal cancer. And you remove the total peritoneum, the lymph nodes, the right and the left peritoneum, the paracolic gutters, the uterus, and wherever the disease is left behind, everything is excised, and give them a complete R0 resection, and then look if they need any further adjuvant therapy. For example, this was, you remember, a young lad in his 40s. I operated on him about a month back, not far. He had a rectal cancer, operated in US, and then after 3 years, he had a low recurrence with peritoneal disease, and he had disease involving the bilateral ureters. One was at the right VUJ, and another was at the lower ureter. So he had a bilateral ureteric resection and reanastomosis, along with a total peritonectomy and an anterior resection. And definitely with the help of my team, a urology team, Dr. Mangesh Patil, myself, and my colleague, Dr. Marzi, we were able to accomplish this surgery, and the patient is now doing well and recovered completely from the surgery and discharged in 10 days. So it's basically what I want to emphasize, the team approach rather than a one-man show. This is the picture of a coloanal anastomosis, wherein you can see the entire rectum is removed and the proximal colon is got down and anastomosed to the anal canal, where initially this would have been ended up with an abdominoperineal resection. But now we can do these kind of surgeries, again, thanks to the advancement in technologies and these kind of retractors called the Lone Star retractor, which I got it from abroad when I came back to India, which enables these kind of facilitate these kind of surgeries. So that's about the open surgery, how that has evolved. Now we all have read it in the books. There's something about notes, and there's natural orifice transendoluminal surgery. And yes, even I had read only in the book. Still, I went to UK, where I realized it's practical, and even notes has evolved from. If you see the various slides, TEMS and notes, So TEMS, that is transanal endoscopic microsurgery. In this, what we do is the patient is put in a lithotomy position. A TEMS scope, which is relatively bigger than a proctoscope, is inserted into the rectum, and through that we put in the rectoscope and a couple of instruments designed for the use of this procedure, and then we remove it from through the scope. We remove the early lesions. So basically, it's indicated for early rectal lesions like T1 lesions, which are not occupying more than 1/3 of the circumference of the rectum, which are not deep lesions. And again, they are kind of in the mid and the lower rectum. Upper rectal lesions are difficult to remove through TEMS scope. And again, it's a surgery done through the natural orifice. So no scars on the abdomen for proven adenocarcinomas up to T1 can be removed through the excuse me, can be removed through the anal canal rather than open approach. However, the only disadvantage with TEMS was you needed a special this resectoscope and a special instrument followed by special training. Surgeons are unfortunately very reluctant to change. So instead of changing their technique or learning their technique, they change the instrument. And sorry, these are a few slides of what we removed on our TEMS scope. So yeah, it's coming back. The surgeons didn't like this new machine, new scope, so they changed the technique and they started using this gel port or a single port called the TEMIS port, transanal minimal invasive. Now in this, the port is inserted into the rectum through the anal canal, and then you use your normal laparoscopic instrument. As surgeons, we are trained to use laparoscopic instrument, and again a deviation from that, we are a bit reluctant to change. So in the TEMIS procedure, you use the laparoscopic instrument, and the vision again is clearer. It's done for the lower rectal tumors with enough not gone deep down, deep into the muscularis layer. So that's what is TEMIS, and this was the first kind of TEMIS scope procedure we did in India, and for a low rectal tumor, a T1 rectal tumor. Again, I say case selection is vital. Just because you have the hammer, you should hit it everywhere doesn't make sense. You have to select your cases well so that you give the best outcome to the patient. So that's the normal laparoscope which is inserted through the TEMS port, and then our laparoscopic instruments to facilitate the surgery. Again, that's not my data. There's enough data to prove the same. And now there's a latest trial coming up, COLOR 3 trial, which is comparing TEMIS versus lap rectal surgery. Should be out in a couple of years and will tell us much better which approach is better for low rectal tumors. So this is now nose, that is natural orifice specimen extraction. Sorry. So in this, what we do is through an abdominal approach, the rectum and everything is mobilized, rectum is resected, and then through a perineum, the proctoscope, large broadband and wound retractor is inserted. The specimen is pulled out through the anal canal, specimen extracted, and the circular stapler anvil is put. It is pushed back into the abdomen, and a circular stapler is inserted from down, and the anastomosis is done from there. And that's how the abdomen looks from the top. So it is kind of, initially we used to make a small 2 centimeter fenestrial incision to extract the specimen. And now with this nose near natural orifice specimen extraction, we are removing the specimen from the anal canal itself and avoiding that fenestrial cut as well. So we have moved, if you see from these slides, we have moved from a large 30 centimeter incision to a few laparoscopic cuts and a fenestrial cut for specimen extraction, and now further down to avoiding any of those fenestrial specimen extraction cuts as well. So this is what things have evolved over time, and so things we need to evolve. The next, what we do is combined endoluminal laparoscopic surgery. Now these are basically indicated when, So in these kind of, for example, when there is a polyp in the right side of the colon, I'm sure all the gastroenterologists agree that it's one of the gray zone area where they are relatively reluctant to remove polyps on the right colon, mainly because the right colon is very thin-walled colon, and the risk of perforation is relatively high as compared to the left colon. So in these cases, and again, if I attempt them laparoscopically, you may not be able to get the tactile sensation. So in these cases, we have a colonoscope inserted on the operating table through the colon. They guide us where is the polyp, and through a laparoscopic instrument, through the laparoscopic approach, we do a stapler kind of staple and remove that part of the polyp. So again, if I do it without the colonoscope, I may miss the target, but with the colonoscope, they can facilitate this visualization. On the other side, if it's in a surgically irresectable position, I can stabilize it with my laparoscopic instruments, and the colonoscopically, the gastroenterologist can remove the polyp. At the same time, we are on a watch out for if any perforation or not. So it's complementary to each other and can work in either direction. And that's what is kind of the combined endoluminal laparoscopic surgery. So this is what things have evolved. And at present, what are the services available? Fortunately, at HN Reliance Hospital, once the curtain is up, you can see everything which is always there in the textbook is available in this under this roof. We have the entire extent of open surgeries, ranging from cytoreductive surgeries to the high-end gamut of robotic surgeries, including high-end radiation therapy and chemotherapy. That's my hospital in the day and night. These are actual photographs and not only to show it here, but that's really my hospital. And so few take-home messages from my slide. In today's era, everybody should be offered a keyhole surgery, and at least offered. You don't need to go ahead with everybody. You need to select your cases, but yes, that offering, you should have it in your mind that yes, probably look for a reason why you want to do it as why you don't want to do it as a keyhole. No compromise. Again, there is no compromise on the oncological outcome. At any point of time you feel your oncological safety is hampered, you have to consider open surgery itself. So there is no compromise at all. And again, just because I have the hammer, I should hit it, doesn't make sense. If it's a large T4 rectal tumor invading into the prostate and the rectum, into the prostate or the back wall, I definitely would prefer to do it as an open surgery rather than laparoscopic surgery. And patient comfort and early recovery is now the necessity. It's a patient-centered approach rather than surgeon-oriented approach. It has to be patient kept in the center and see what the patient really wants and make your treatment feasible around it, so that if he's happy, you will be happy. And that's how things have evolved. And that's why we still say necessity is the mother of invention. These are the two famous quotes I always tell to all my juniors, and I learned it from my mentor, Mr. Charlie Hendricksy from UK. And he used to say, as a surgeon, learn to say no. Surgery is a skill which you can acquire it by doing 10 or 12 surgeries. But it's an art to say no when to surgery. And yes, I always appreciate to be a physician who can operate rather than be a surgeon who can operate. Thank you, everyone. Thank you for giving your questions. And that's myself in my different approaches, open, lab, and robotic. Everybody should be offered the entire gamut and select your case based on patient selection rather than your gut feeling. Thank you. Thank you again, once again, IMA, for giving me this platform to see where we are heading towards in colorectal surgery. Thank you.
So thank you, Dr. Paresh Jain, for wonderful presentation. And I think robotic surgery and keyhole surgery or laparoscopic surgery is here to stay and is going to grow. Is there any question? I think I don't see any questions. So we thank Dr. Paresh Jain for a wonderful presentation, and we now start next lecture.
Thank you, sir. Thank you.
Thank you so much. So the next lecture is by Dr. Amar Pazare. Dr. Amar Pazare is Professor of Medicine at Somaiya Medical College, Mumbai. He is also coordinator of the AIDS Core Committee Unit and Nodal Officer, ART Center at Somaiya Hospital. He did his MD and MBBS from Nagpur University, followed by a fellowship in HIV disease from USA in 2003. He was professor and head Department of Medicine of prestigious GS Medical College and KEM Hospital. And he was an active member of many organizations and attended numerous conferences. He is an associate editor of Journal of Association of Physicians of India and has written chapters in the API textbook. He has published many papers and conducted CMEs and workshops and seminars. So without wasting much time, I request Dr. Amar Pazare, who's a fantastic teacher himself, to speak on interesting cases in HIV/AIDS. Dr. Amar Pazare, please.
Thank you, Girish. Thank you, IMA, for inviting me for the lectures. I am taking 3 short cases and practical cases where every person, every physician should know the care of the HIV positive patient, and very simple cases. First case, 40-year male taking ZLE for 10 years. I think everyone knows about its combinations and short forms for the, because it's all short forms made by the NACOs. Everyone knows about ZLE. No complaints, no signs of opportunity infections, compliant with ART for 10 years. His CD4 gradually increased from 145 to 43 to last one was a 512. Little bit drops at the last one. Viral load was initially above 4 lakhs. And after that, it's always target not detected till end. Still the last report is 1700. So recent report is a CD4 count is a 512 and viral load 1700 after the 10 years of ZLE. The problem is that what we'll do for this case? What is next action? Is it virological failure, or, and if it's viral failure called as a viral load more than 1000 copies per ml, then it's called viral failure. You go for genotyping or you go for the repeat viral load after 1 month. That's the questions. If genotyping is done, generally it shows the M184V mutation, which always suggests the resistance to lamivudine. So it is immaterial. So ideally you should not go for the genotyping. You just repeat your viral load after 1 month. If it's still high, more than 1000, you can go for the genotyping if you want. But most of time, it is within a 15 days to 1 month, it will come to normal, not detectable level. So it is a transient viremia because of anything like any infections, viral fever, or any trauma, any surgical procedure, any stress, strain. All things can cause the intermittent viremia. This is called as the blips. So viremia temporarily in this case called as blips. Generally should not go by genotyping, go for repeat viral load after 1 month. You should not change any ART in this patient. No need for genotyping. And 184V mutation suggests the mutation for lamivudine or emtricitabine. That is 3TC and FTC. And that will cause the virus weak. The base mutation is not always bad. This is the base mutation patient should have. If it is there, virus become weak and is more susceptible to the other drugs. It is killed easily by the other drug. AZT works more or 10 times more or 20 times more potent to kill the virus. So we want this mutation in the patient, him 3TC, FTC, lamivudine, continue throughout life to maintain this mutation. So we never take out the lamivudine from the anything. Or sometimes all drugs fail at the end of the disease. Still 3TC, FTC may continue palliative therapy because it will cause a slow growth of the virus. The growth will be there, but the growth will be hampered. For example, it is without 3TC, it will be in 1 month, 1 lakh become 2 lakhs. But with 3TC, it is 1 lakh into 1,20,000. So that is the growth will be reduced by the 3TC, FTC. So that's why we continue 3TC, FTC in spite of the mutation in all the throughout life to the standard therapy and without any side effect, cheapest drug without any side effect. So this is a base drug we can continue throughout life in all the patients. So this is second. So one message from this is should not bother about the small viral load 1700. You just repeat a viral load after 1 month and see that if it is more than that, go for genotyping and change of regime. It is less than that or come to normal or come to target not detected, continue same medication without any modifications. Now, second case. A 50 years man on ART TLE. This regime that is now accepted by the NACOs. So TLE, tenofovir, lamivudine, efavirenz. This is a single tablet since 7 years, but it stopped since last 6 months. So 6 months it do not have the non-compliant for the drugs. His CD4 now 386 and viral load is a 46,920 copies per ml. So this cannot be blips because blips generally occur around 1,000, 2,000, not like a 46,000. So blips is not definitely there. Viral load is definitely high. Now what is the next step? If you do the mutation, for example, this one, problem in this patient is that, is it because of stopping a failure or because of the mutations? So we do the then mutation. Genotyping because very high viral load. So there is no mutation except M184V, which is a insignificant for us. We never change the drug for that. So question is that why there is a high viral load in spite of the no mutations? All drugs are working, but there is no mutations. Explanation that after stopping ART, there are two strains called wild and resistance mutation virus. So wild means original virus and resistant virus, both are in the blood. Wild virus, which is not resistant, multiply very fast, 10 times faster than resistant virus. Resistant virus is a multiply slowly. Hence, genotype pick up the only wild virus, which shows no mutations. So the viral virus give the report of no mutations, and resistant virus is small in number that won't give any resistant pattern. So that's why there is a no mutation in this patient. So explanation I've already done. So this is the phenotyping. Hardly we do nowadays. Phenotyping is not required nowadays. We do only genotyping. What is the ideal management? Continue same ART for 3 to 6 months. This will suppress the wild virus completely. Whatever virus remains in the blood is the resistant virus now. So resistant virus, after that you go for genotyping, then you actually the mutations. So you should not do the immediate genotyping. We should wait for the 3 to 6 months. Then wild virus suppress, and then for resistant virus we get a genotyping. Actually, if patient is TLE or TE, that is tenofovir, lamivudine, emtricitabine or efavirenz, actually there is no genotypic required because we get this mutation only. So we expect mutations after genotyping are the 184V, lamivudine, so we're not going to change it. K65 are tenofovir and K103 for nevirapine, efavirenz. So the 3 mutations only will get on the TLE. And if these 3 mutations are there, this will cause a 184V and K65 are these 2 mutations I told you for the lamivudine, tenofovir. If these mutations are there, it will cause a AZT hypersensitivity because there is no TAMS. So AZT become more hyperactive if patient has these 2 mutations, M84 and 65. M84 virus weak, so we continue lamivudine. And K013 is an NRT resistance, that is a efavirenz and nevirapine. So we are not using this one. So we have the 3 best drug now. AZT hypersensitivity, AZT will be used, lamivudine will be used, and we use a third drug like NEPR or INSTI, that is dolutegravir. So we can use without any genotyping directly ZL, that is the AZT and lamivudine, and at third drug, because NRTI use, you cannot use the efavirenz and nevirapine, so they are cross resistance. So we cannot use that. So we have the PI or INSTI, that is the dolu. So other drug available in India are the integrase inhibitors, raltegravir, dolutegravir, protease inhibitor, atizanavir, lopinavir, darunavir, and CCR antagonist, that is maravir. So any of the third drug can be used. Of the all drugs, which is the best drug? Second line option after TE or TLE or TE in the first line, without genotyping, you can use AZT lamivudine as a backbone. We can another drug, atizanavir, lopinavir or darunavir, all boosted, anything can be used, or dolutegravir can be used. Raltegravir is no more because it's a higher dose and it's two BDs and etc. So it is single one OD. Better than raltegravir, so use this drug. It's a very good second line combination. And for this starting this combination, we do not require genotyping. So ideal treatment will be the for June 15, WHO recommends ART for all people living with HIV in respect of the CD4 viral load. It's called test and treat, and fast track initiative to take care of the HIV or to eradicate HIV from the world by 2030. That's what they're planning. As per NACO, this recent changes there, 2020, that is 20, just in I think maybe 3-4 months back, they have changed up all these regimes. TLE or TE, if they are on, they won't change. They continue as it is. If patient is tolerating, patient is not in failure, we're continuing this TLE as it is. But all ZLE, ZL patient, AZT patient, ZLE, ZLE, all patients are shifted to TLD, tenofovir, lamivudine, dolutegravir combination. It's a single tablet. To start all new patients on TLD only, 1 OD, FDC, single tablet. So all patients of ZLE, ZLN shifted to the TLD, or all new patients on TLD. It has this side effect. It contains TDF, lamivudine, dolutegravir. So now the recent treatment, all new patient and ZLE patient all shifted to TLE, the best drug nowadays. This is all as per NACO. Patient either on TLE, if is already taking, a new patient on the ZLE patient on the TLD. Now the third case. 38-year-old female, symptomatic since 2 months and presented with the left hypochondriac pain, intermittent, dull aching. She has a headache and general weakness. Examination, abdomen, she has a soft, non-tender liver, non-palpable liver. But spleen was palpable 4 cm below subcostal margin, non-tender and firm. So only positive findings are the spleen palpable on the abdomen. But on face, if you can notice, she has plethora, she has quite a red tongue, the eyes are congested surface. So this is suggested to the polycythemia. So she has a more hemoglobin. So hemoglobin was 17 gram %, PCV 55 gram %, 50%. CBC, polymorph lymphocyte eosinophil normal, no blast cells, platelets were normal, but she was HIV positive. LFT, RFT normal. EPO level is slightly lower than the normal. ABG, she is almost normal. Saturation 95%. pH is slightly alkalotic. XHS normal. JAK2 mutation present. So possibly we will rule out the is it hypoxia causing the COPD asthma, COPD-like symptoms causing the polycythemia, or patient has got some blast cells, but nothing was there. So final diagnosis was a polycythemia vera in HIV positive patient. Criteria diagnosis polycythemia vera, as per the polycythemia vera study group and WHO, at least 3 criteria should present for the following. Hemoglobin more than 16.5 gram % in males and 16 gram % in females. Arterial saturation should be more than 92%. Splenomegaly, presence of JAK2 mutation, bone marrow showing the hyperstability. So I have not done bone marrow because already 3 or 4 features are matching with the our diagnosis. So only 3 present, we had a 4 criteria, and 5th one we are not done. Most HIV positive patients have the anemia because various etiologies, maybe because of drugs, maybe because of nutrition, maybe because of diseases like tuberculosis. But it's very rare to have the polycythemia in this patient. Now, is it causal relationship or is it something HIV is responsible for the polycythemia? Maybe it's just coincidental finding polycythemia disease than HIV, or the scientist says that HIV plays role in the generation of the metabolic disorder, like it can cause various malignancy. So it also can cause sort of polycythemia. Maybe the HIV may be responsible for the polycythemia because it has a myeloproliferative properties. So that possibly this may be reason, or this may be just coincidental disease. Very few cases in the literature are described. One such case by the M.G. Sakasi, polycythemia positive patient. He was treated with AZT, DDI, lamivudine, sequinafir, but polycythemia persists. Then they started on hydroxyurea and phlebotomy. So it results in drop in. So drug, AZT drug or ART, even if its viral load goes down with the drugs, it will not, polycythemia will be go back, possibly. When you separate treatment for polycythemia, even viral load is less, it will not go away. So the treatment for polycythemia are the phlebotomy, imitamab, interferon, myelosuppression drugs, and bone marrow transplant. So this is the curative treatment. HIV treatment, any regime can be started in patient. AZT-based regime was tried considering it may work because of it is AZT is a myelosuppressive drug. It can cause bone marrow suppressions. So possibly this may cause the improvement in polycythemia, but it won't work. It is not working. So additional drug has to be given required for polycythemia. Hence, as per WHO, we started patient on the TDF lamivudine dolutegravir, started quite 1 or 2 years back only, this recent patients. So patient needs a separate therapy for polycythemia and separate for the AZT. No, there is no drug interaction. If hydroxyurea use, then possibly we don't use the AZT because it will cause a bone marrow suppression both the drugs. So we have some little problem. But most of the drug, TLD is safest drug we can use in this patient of polycythemia. I think it's a third short case. Thank you very much. Any questions? You've been invited. Thank you very much.
Thank you very much, Dr. Pazare, for very lucid and crisp presentation. I think it is very, very useful. That one small thing Dr. Narendra wants to know, shifting of ZLE to TLD, whether it is recommended by NACO.
Yeah, it is a new rule of NACO now. NACO only has changed this regime to the all ZLE, ZLN to the TLD now.
Okay.
Only this we have shifted quite long back, but NACO has somewhere in the February they started this regime, but because of COVID they could not get the drugs till now. Now since last 2 months, September, they have started giving the drug to the TLD to new patient. And all patients ZLE, ZLN shifted to the TLD now.
Okay. So thank you so much, Dr. Pazare. And now I think we will go to the last presentation today.
So friends, Dr. Mala Kaneria is Professor and Unit Chief, Department of Internal Medicine at Nair Hospital and Topiwala National Medical College. She is also Professor and Unit Chief, Kasturba Hospital for Infectious Diseases and Consultant of Infectious Diseases at Jaslok Hospital and Research Center. She did her MBBS and MD in Internal Medicine from LTMMC Sion Hospital. She has 25 years of vast teaching experience for undergraduate and postgraduate medical, dental, physiotherapy, and nursing students. She is the examiner for third year MBBS students, dental students, and MD students at MUHS. She is a recipient of many awards and prizes throughout her illustrious career. She has more than 80 publications in national and international peer-reviewed journals. She has been a member of many renowned professional associations and has been a part of several projects. She is on the advisory board of the Journal Association of Physicians of India. Her areas of special interest are tropical infections, vector-borne infectious diseases, pulmonary and extrapulmonary tuberculosis, opportunistic infections in HIV, and antibiotic resistance. I request Dr. Mala Kaniar to please take over.
So thank you for the very kind introduction. And at the outset, I would like to thank Dr. Girish Rajadaksha and the IMA for having me on this talk on a very important and a very challenging topic. Now, all the lectures which I have heard since morning on oncology, nephrology, and the other speakers, as compared to them, the topic that I am going to speak on is something which all of us, including physicians and doctors from other faculties such as plastic surgeons, orthopedicians, dermatologists, anesthetists, everybody has great experience on, because this pandemic, which has been of a very unprecedented magnitude, has led the government to pull all the doctors into treating this pandemic. And we are all on a similar, identical learning curve, and there are many knowledge gaps which we all need to address together. COVID-19 has hit the world mostly unprepared for a massive pandemic due to a new coronavirus with widely diverse clinical phenotypes ranging from completely asymptomatic expression at one end of the spectrum to septic shock with rapid death at the other end of the spectrum. Because there is no cross immunity with other coronaviruses and barriers to virus dissemination have not been optimal at the beginning of the viral spread, this pandemic has rapidly overwhelmed the healthcare systems across the globe. Now, as we all know, there is this huge spectrum where at one end of the spectrum, we have patients who are asymptomatics or who are just happy hypoxics. And at the other end, we have patients who somehow land in the ICU and require invasive forms of mechanical ventilation. Now, one of the biggest mysteries on this earth is why some patients land into the ICU and are not salvageable and others don't, whereas they share the same risk factors. Now, the triple burden of HIV, TB, and COVID-19 is a major global health challenge of the 21st century. Now, the HIV and TB co-infected countries, which have a very high burden, for them, a patient who is living with HIV having a COVID infection is a well-founded concern, and it's a triple whammy for the patient as well as the doctor. So how does the COVID-19 impact our lives in HIV? Now, we all know the scale and the magnitude of this pandemic. It has caused an unprecedented disruption of lives due to lockdowns. HIV/AIDS centers globally have been converted to COVID-19 treatment centers, which denies the patients of their HRT. HIV physicians, including physicians from all other specialties, including plastic surgeons, pediatric surgeons, anesthetists, everyone has had to abandon their original duties, and some have actually had to engage fully in COVID-19 cases because of the magnitude of the pandemic. Patients have kept away from accessing their ART refills due to fear of contracting COVID-19. Also, a patient who is well controlled on ART somehow has had relapse or has suffered from OIs because of shortage of medications, as medical consignments are stuck in procurement systems in other countries with no further supplies able to come in. And most importantly, as all of us have experienced, it has compromised the psychological and the emotional well-being of people living with HIV. So as all the manpower, the attention, and the resources have been diverted to COVID-19, we have observed that the annual incidence of infectious diseases, it could take a big hit, and all the programs or all the infectious diseases which the government had planned to eradicate by 2020 are going to be on the back burner as all our resources are diverted towards COVID-19. Now, several medical comorbidities are supposed to be or identified as risk factors in COVID-19. Now, clinical evidence shows that disease severity and morbidity is associated with advanced age and with the presence of medical comorbidities such as diabetes, hypertension, CKD, cardiovascular disease, solid organ transplants, leukemias, lymphomas, etc. However, it remains unclear whether there is an increased risk of COVID-19 and severe disease manifestation in HIV patients. Now, this concern for a patient of HIV having severe manifestations of COVID-19 is probably on the assumption that people living with HIV are more likely to be immunosuppressed. They have abnormal humoral and cell-mediated immune responses resulting in increased number of opportunistic infections. There is a particular concern for people living with HIV who have a low CD4 count, advanced disease, a higher viral load, and those they are not yet on ART or who are not compliant with ART. And now we know that HIV is, though it is incurable, it is considered to be a chronic disease, just like diabetes and hypertension, where if the patient takes his medicines regularly, is going to live for a very long time. So because people are living longer with ART, many are also going to have the chronic conditions which are associated with severe COVID-19. And there is a controversial suggestion that HIV infected individuals could be protected from severe COVID-19 due to their ART or because of HIV related immunosuppression. Now, in this COVID pandemic, is the presence of underlying HIV a boon or a bane? So, there is an increased risk for COVID-related complications in HIV. It is presumed due to a higher rate of coexisting conditions than in the general population. The dual lymphopenia, which is caused by HIV and COVID, may enhance the immunosuppression and thus cause such a patient to have an increased risk of bacterial, viral, fungal, and other infections. Also, we have to deal with the adverse effects of antiretroviral therapy, especially when you're giving them other retrovirals and immunosuppressants like remdesivir and tocilizumab. The presence of other opportunistic infections may give rise to diagnostic and therapeutic dilemmas. And these patients have the usual traditional cardiovascular risk factors such as obesity, alcohol, hypertension, diabetes, etc. And on the other hand, now we know that all the severe complications of COVID-19 are because of the cytokine storm and the dysregulated immune system. And it is thought that probably the HIV-related immunosuppression and the lymphopenia may paradoxically protect against the severe manifestations of COVID-19. And there is earlier data which has shown that some antivirals such as tenofovir and lopinavir, which are the ART, may have some activity against SARS-CoV-2, and also the remdesivir, which is a drug which was shown to work in SARS-CoV-2, may also have some action against HIV, and all this may lead to a protective effect. Now, the collision of the two pandemics, or rather the three pandemics, TB, HIV, and COVID-19, brings us to some very urgent questions which need answering. Number one, does HIV infection actually increase the risk of getting COVID infection? Is the presentation in HIV patients identical to that in the non-HIV population? Does the low CD4 and undetectable viral load confer protection against the severe manifestations? Does antiretroviral therapy have a protective effect? Does the presence of HIV alter the disease severity of COVID-19? Is the mortality higher in co-infected patients? Are secondary bacterial fungal infections more common in patients who are co-infected with HIV and COVID? Is viral shedding with viral virus more prolonged in these patients who are co-infected because of the immunosuppression? Are immune responses, that is the antibody production as well as the T-cell immunity, which we all know now is very, very important in COVID, are they identical in COVID co-infected patients with HIV as in non-co-infected patients? And are the patients who are HIV and COVID co-infected more prone to have reactivation and reinfection? So there are some studies which have answered some questions, though we do not have all the answers. So I'm going to address a few studies to see where we have reached in our knowledge. So this is one of the earlier studies, a systematic review, which evaluated 252 patients out of 25 studies. And in this study, it was seen that the mean age of the patients was around 52.7 years. Most of the patients were males, only 18.3 were females, and 2 were transgender women. Now, as we have seen, even in COVID patients who do not have HIV, there is a male preponderance in COVID-19. This is possibly because the X chromosome has some protective effect in females. So just like in a non-co-infected patient, in HIV COVID co-infection also, there was a male preponderance. Out of the 251 patients in these studies reporting the ART status, only 2% were not taking ART. So 98% were on ART and majority were virologically suppressed and had higher CD4. So only 13.1% of the patients had a low CD4 count. The viral load data, which was available in just few of the patients, showed that the high viral load was there only in 2 of the patients out of 233 patients, but the data was available. The main clinical symptoms of COVID-19 in people living with HIV were cough and fever, which is comparable to HIV negative people, and 66.5% of the patients had mild to moderate symptoms, just like in a patient who does not have a co-infection. Now, when all these patients of co-infection were considered, it was seen that all of these had some form of multimorbidity. So they did not have isolated coexistence of only hypertension, obesity, or diabetes, but they had more than one comorbidity along with your HIV. So these multiple comorbidities were present in 2/3 of the patients. The majority of the patients were hospitalized, and 16.8% of these co-infected patients were admitted to the ICU. Now, they say that this could be due to the fact that the studies which have reported these patients were all predominantly of hospitalized patients, and therefore there is this skewed data. Now, the proportion of death amongst patients who are co-infected appears to be rather high. It is almost 14.3%, with 85.7% being males. So that more death in males is also seen in patients who are not infected with HIV. However, these studies showed that there was increased mortality in patients who were co-infected. But the authors say that we have to be really cautious in interpreting this data, because when they actually analyze all the deaths of co-infected patients, they found that all of these patients had multiple other comorbidities, and the deaths were not particularly due to the HIV infection, because the patients who died were biologically suppressed and they had a CD4 which was more than 200. Now, many of these patients were on ART also, including PI-based ART, but the ART was not exactly protective. So people living with HIV can be infected with COVID-19. They are not protected. They are largely affected by similar features of disease risk and progression as HIV uninfected patients. And another reason why more number of deaths was documented in these co-infected patients was probably due to the preponderance of publication on hospitalized patients in more severe disease. So there is a large chunk of HIV and COVID co-infected patients who probably don't reach the hospital because they have a mild infection. This is another study, which was an earlier study, which was published sometime in July. This evaluated 378 patients of co-infection cases which were reported globally. So what this study commented was that there were only 2 cases reported in the earlier days from South Africa. Now, this is very, very surprising, because South Africa is the epicenter of COVID. It is the hotspot of HIV, where there are 8 million cases, with the largest HIV epidemic in the world being seen in South Africa. So why is it that only 2 cases were reported, and there were 101 from UK and 122 cases from USA? This is probably because all the underdeveloped countries like South Africa, they do not publish their data much. Their healthcare system is not very robust, and therefore there is this skewed data where we have all this data of co-infected patients from countries which do not have as many cases as the people from the underdeveloped countries like South Africa, where HIV is a big problem. Now, this study also said that if you consider studies from Italy, Spain, Turkey, and UK, which characterize COVID-19 HIV cohorts, the prevalence of HIV COVID co-infection was just 0.98%. Whereas if reports from China, Japan, Spain, UK were considered, the incidence of HIV COVID co-infection was just 0.64. This is very low compared to the fact that in COVID plus CVD, the incidence was 16.9 to 56.6%. Whereas in COVID plus diabetes, it was 8.2 to 33.8%. For respiratory infections, it was 1.5 to 17.7%. And several other studies too among large populations have observed that people living with HIV made up approximately less than 1% of COVID-19 cases, which is actually the tip of the iceberg. So the authors caution that these lower rates of co-infection are possibly because there is scant literature to date, because it is not being reported, possibly because a large number are asymptomatic and mild, and all the literature is reporting only those patients which are actually hospitalized due to moderate to severe infection. Secondly, it is quite possible that the HIV infected patients are probably following safety precautions like wearing a mask, hand hygiene, social distancing to a greater extent, because of their already immunocompromised status, and the fact that even before COVID-19, HIV patients were at increased risk of a broad range of infections, including RTIs. And they say that this lower rate of co-infection is not due to the protection afforded by HIV or ART. And also probably lower number of HIV population is being screened for COVID-19 as their visits to ART centers have diminished because of the fear of COVID, even for their ART refills. So the same study says that in that study, majority of the patients were virologically suppressed on ART, yet that does not prevent the progression to severe COVID-19 or even death. There was no evidence of association between viral suppression status and severity of COVID-19 or the outcome. Like in the previous study, majority, 64.7% year 2 were mild or uncomplicated. 35.9% of the patients required ICU care. And here again, the case fatality rate was very high, 14%, which was 2 times higher in UK as compared to the general population, and 2.4 times higher in the US as compared to the general population. So again, they say that we have to really look at this data very, very carefully, because we cannot, this data is not peculiar to HIV and COVID co-infection, because all the majority of the hospitalized patients in UK and US, they were reported as dead. So therefore, these patients who died actually had multiple other comorbidities, and HIV may not be the cause of death in these patients. Another study which was done in only 23 persons, all were more than 18, all were blacks, and this also showed that there was no difference in mortality, ICU admission, and the need for mechanical ventilation when compared with the matched control for COVID-19 patients without HIV. All were discharged home alive after medical management, which included administration of steroids, antibiotics, and respiratory support. This study was an earlier study which did say that probably CD4 lymphocytopenia protected, but their numbers are only 3. So in 3 of their patients, one patient had a CD4 of 10, one had a CD4 of 116 and one of 179, and only one patient died. But this number is really very small to be of any meaningful conclusion. There were other observations from some study. This was an earlier study from Wuhan, which said that co-infection with HIV and COVID may severely impair the immune system. And based on the observation of a delayed immunoglobulin antibody response, this may prolong the course in an HIV patient. So this study mentioned that the IgG production was lower in co-infected patients. And this was just one patient where they felt that the lung changes did not reverse early as compared to non-co-infected patients, and they had a prolonged stay. But today we know that in COVID-19 patients, even the patients who have pure COVID, where there is absence of HIV, they also have a prolonged time where their lung involvement is seen. So therefore, we really cannot deduce much from this study. Now, does ART have a protective effect on COVID-19? So in a study in Lancet, they actually tweaked the patient. There were 5 patients and they tweaked the ART of these patients. So if the patients were on non-PI based regimens or ART, they tweaked the regimen for a couple of days to convert them to PI based regimen after taking consent, and later on switch them back to a non-PI based regimen. The reason was because the earlier studies said that ritonavir boosted lopinavir had a protective role in COVID. But the Lancet study did not show that ritonavir boosted lopinavir had any protective effect in COVID-19. So all these trials did not show that ART protected in any way. Neither did it protect the onset of symptoms, nor the presentation, nor the severity, nor the mortality, nor did it decrease the period of viral shedding in COVID-19 and HIV together. And the findings of low morbidity or mortality among patients on ART compared to those non-ART would also need to consider a higher CD4 count and a better immune status of these patients. So the inferences which we can draw from these studies is that, number one, people living with HIV can be infected with COVID-19. They are not protected. They are largely affected by clinical features of disease risk and progression as HIV uninfected patients. There is a male predilection, age predilection. Symptoms are similar in both co-infected patients and COVID patients. Majority suffer from mild symptoms as in the general population. The ICU requirement and the mechanical ventilation requirement do not differ between the two groups. Mortality appeared to be a little higher in the co-infected groups, but here they say we have to take these findings with a pinch of salt, because these patients have a lot of other comorbidities which could have contributed to the higher mortality. ART does not offer any protection against infection, worse outcomes, or mortality. HIV and SARS-CoV-2 are likely to exhibit a synergistic effect on immunity in serious cases of HIV COVID co-infection. Lower CD4 counts and higher viral loads may be associated with worse outcomes. Now, these studies have not really uh, looked at the very important fact that incidence of secondary infections, bacterial and fungal, is it higher in the HIV group, because we have seen that patients of COVID-19 who are diabetics and who receive steroids and some who receive tocilizumab, they are those really kind of immunocompromised patients, and if they have HIV also, it's a perfect recipe for disaster, and they would be more prone to have secondary bacterial and fungal infections. So there is no study really addressing this concern. Now, antibody response in HIV COVID patients may be lower, and this may lead to prolonged symptoms, delayed lung killing, and a prolonged viral shedding. But I did not find adequate studies to address these concerns, because this is something which we really need to look into, because we are all hoping that a good, robust antibody response will prevent reactivation and a reinfection. So are HIV COVID patients more prone to reactivation and reinfection? So this is something which we require further studies into. And also HIV with HIV patient with a proper ART does not worsen the COVID-19 course in comparison with the control group of COVID plus and HIV negative patients. So this is some NIAR data which I want to share. So I have the data of only 30 patients. Now this is actually the tip of the iceberg. Now you will wonder why this number is so small. This number is so small because firstly is that the government and the local authorities, they kept on changing the requirement of admission. There was a time where every patient who was positive had to be admitted. And then when the hospital cots were full, that time they restricted the admissions to only patients who really required oxygen, etc. And also many HIV patients who are mild, so not coming to the hospital. And also this is the data of only just 2 floors in our hospital. Thirdly, these patients were being looked after by individuals or doctors from other specialties such as anesthetic, pediatric surgeons, etc. So a lot of papers did not have the fact that the patient is RVD mentioned because the patients were relatively stable. So anyway, out of these 30 patients, we have the data of 19 patients. Out of these, 25 patients were discharged. They were having mild to very moderate symptoms. Majority were mild. Most of them were on ART. The CD4 was more than 200 in most of the patients. Most of the patients, 15, had comorbidities. Out of these patients, only 10 required supplemental oxygen, 5 needed ICU care, 3 required ventilation. Inflammatory markers were uniformly raised in all the critical patients. None had coexistent opportunistic infections at that time, possibly because the CD4 counts well above 200. Out of these, 4 expired. This is a rough data. The HRCT thorax part can't be seen down, but all of them had 50 to 75% involvement. Now, majority of patients did have comorbidities, though it is not mentioned in the slide. Patient number 3 had a dilated cardiomyopathy. All of these patients had RVD since a very long time. Just one was newly detected. All of them were on ART. There was just one last patient, number 7, who was a recently detected RVD who started on TLE. Majority had CD4 count, which was, at least these patients, the CD4 count is near about 200, but the others had well above 200. There's one patient whose CD4 was less than 65. All of them came with respiratory symptoms. All of these required oxygen except patient number 6. And these were the reports. Now the LDH CRP are not mentioned in this slide, but all of them had high inflammatory markers. Now, if you look at the interleukin 6 in these patients, there were 2 patients whose IL-6 were low. Patient number 2 was 8.95 and patient number 7. However, both these patients died. So what I'm trying to say that I saw in my experience that there were many patients with IL-6 of more than 5,500 who were moving around without oxygen, very stable. And there were patients who had a low IL-6 who actually died. So IL-6 levels really were not correlating with the clinical severity. Now, out of these, the patient number 1, 2, and the patient number 5 and 7, they died. Now, majority of the patients were positive at the time of death, and this positivity of the swab, RT-PCR, which is seen in all the patients, was also seen in patients who were HIV negative. So we have seen that patients were not getting converted to negative for a very long time, and this was not peculiar to HIV COVID co-infected patients. Now I come to another aspect of the story. This is a patient who had TB. Now this patient was there for almost 2.5 months. He had around moderate COVID, required O2 for a very long time. He did not have a history of TB, and this patient did not require tocilizumab because he didn't need it and it was not available. He did not require remdesivir. All he required was steroids for around 10 to 12 days. And you can see the X-ray. The X-ray which is shown on the left side was when he first presented. Around 3 to 4 CTs were done in this patient because his oxygen requirement was not decreasing beyond 1 to 2 liters, which he was requiring, though he was stable. And he developed a cavity right in the ward over a period of around 2.5 months. His galactomannan was slightly high, but it could have been false positive because he was on piperacillin and tazobactam. And eventually his gene expert came positive. This is to highlight the fact that the velocity of development of TB in this patient was so far. This is probably because of the immunosuppression which is caused by, so SARS-CoV-2 could induce a transient suppression of cellular immunity that further predisposed patients to exacerbated reactivation or to new TB infection, as in the case with HIV. And if this patient had underlying HIV, or like this patient receives steroids or a tocilizumab, which is a biologic which causes immunosuppression, or he had diabetes, which this patient did not, which most of the patients had. So this would be a sure shot recipe of an infection like TB. So therefore, a patient who has TB plus COVID plus HIV would be particularly challenging, because the treatment in this situation also would be challenging because we have to look at a lot of drug-drug interactions and adverse effects. Now, these are a lot of patients which I saw who had COVIDs. So there is the patient on the upper side, right-hand corner, had aspergilloma. The patient on the lower side, left-hand corner, also had an aspergilloma. And the patient in the right lower corner had developed a pulmonary. This is also, now all these patients' CT, the third or fourth CT, which was repeated because the O2 requirement was not diminishing, and they required a prolonged stay in the hospital. So in the last patient, there is a lot of pulmonary microthrombi and a pulmonary infarct, which is converted into a cavity. So we have to look at all these cavities and other presentations in patients who have a prolonged oxygen requirement in COVID patients. And this is particularly challenging in patients who have HIV in addition. Now, in a patient who has got HIV, the ground glass appearance that we talk about, now many patients, as we all know, they are RT-PCR negative. And if they have the clinical presentation of COVID, we like to look at the HRCT, even if and we tend to treat them as COVID, even if their SARS-CoV-2 is negative, especially in the first 5 days. So in this situation, when we talk about ground glass opacities, we must remember that ground glass opacities are a very common cause of certain pneumonias in HIV, such as a PCP or a HSV pneumonia or a CMV pneumonia, or a bronchiolitis due to respiratory syncytial virus. So there are case reports which have shown that a patient presented with PCP, but because the patient presented with shortness of breath and ground glass opacities, he was treated as COVID, and later on turned out to be HIV and PCP. So this patient was not a diagnosed HIV, but the first presentation of the patient was with an OI, which happens very commonly. On OI, patient of HIV presenting with OI, which is PCP, and getting confused with COVID in the current situation because the presentation is identical, that is shortness of breath, decreased saturation, and ground glass opacities on the CT. Therefore, in these two slides, one patient is GGOs due to COVID and one patient is PCP, and it's very difficult to distinguish between the two, although they say that in COVID, the GGOs are peripheral. Now here, the one CT which is showing peripheral opacities is actually the PCP. So one has to be really cautious in interpreting this when you have a patient who has a dual infection of HIV and COVID, and you have to think about the other OIs also in the correct scenario. Now, COVID is supposed to be a prothrombotic state. HIV and TB are also supposed to be co-thrombotic state. So we have had patients who have had HIV and COVID and who have developed these deep venous thrombosis. So one has to be very, very cautious, because in COVID, all of us have observed that there are young patients who have come with stroke or DVT or thrombi in different parts of the body, even young MIs. So because HIV is an inflammatory condition and a prothrombotic state, and so also COVID, therefore this is another complication which we really need to watch out for in these patients who are co-infected. This is a patient of mine who was really very bad, who was HIV positive, COVID positive. He had a prolonged stay of 2.5 months in the hospital, but yet he survived. 53-year-old male, RV since 20 years, dyspnea on exposure since 2 to 3 days, positive RT-PCR on 21st of June. Last CDR was 312. He was on ART, which was non-PI based. He had a background of ischemic cardiomyopathy, had acute LVF in 2017, where the ejection fraction was just 20 to 25%. On presentation, he was tachycardic, tachypneic, conscious oriented. The PaO2 by FiO2 ratio was 130, transferred to the ICU. He was maintained on HFNC, NIV, did not get mechanically ventilated. Inflammatory markers were all high. MCV was high 130 because he had been on ZLN a while ago. SGPT was 165, which is a very common observation in COVID patients. So COVID per se can cause a rise in SGPT as compared to SGOT. Hemoglobin A1C was 7.1, though he was not a known diabetic. This was the HRCT thorax, which showed, besides the HRCT, a thin-walled cavity abutting the right anterior costal pleura with a few internal septations. He was worked up for this. Gene expert was negative, GM was negative, fungal culture was negative, and he had a moderate hepatomegaly, which is again very common in HIV patients because of hepatic steatosis. Now, this patient was given antibiotics, he was given ivermectin, steroids, he was given inotropes for his low LVF. His RT-PCR was positive on the 18th of July. Then finally, after 1 month, his RT-PCR became negative. But he required 2 liters of O2 for a very long time. Finally, after 2 months of stay in the ICU, he was transferred back to the wards. He could be weaned off after 2 months, and a repeat HRCT showed no fibrosis and no changes. Now, this person came for a follow-up on the 29th October to the OPD. He just complained of 2 episodes of hemoptysis, and he was readmitted. His RT-PCR for COVID at that time was negative, but his HRCT now showed that the cavity which was there earlier, now in that place there was a consolidation with pleural tagging abutting the right anterior costal margin. And in the previously mentioned cavity, there was this consolidation. So they said you have to rule out a neoplastic etiology. And now there were fibrotic changes of typical COVID pneumonia. So pleural biopsy was planned to rule out neoplastic etiology. A whole body PET scan is done on the 1st of December and the report is awaited. So this patient had a very stormy course. And in spite of having HIV, he survived. He is well today, but he needs to be worked up. He's currently at home. He's supposed to follow up with his PET scan. So the challenges which we face in HIV, COVID, co-infection is diagnosis of COVID in HIV may be challenging due to overlapping respiratory symptoms in HIV, due to TB, non-tuberculous mycobacteria, pneumocystis jirovecii pneumonia, etc. The ground glass opacities on HRCT can mean either PCP or a typical viral infection in a patient with co-infection. COVID can worsen the lymphopenia already present in HIV patient. The profound immunosuppression can make them vulnerable to OIs, which may be difficult to diagnose. The steroids and tocilizumab given for COVID and the coexistent DM, which is practically universal, can exacerbate these OIs. The rate of drug-drug interactions would be higher with all these combination. Fungal infections are common in COVID, that is COVID-associated pulmonary aspergillosis and Candida infections can occur with profound immunosuppression in co-infected patients. Patients on ART and ATT, especially rifampicin, you have to watch out for liver function test derangement, especially when you're giving remdesivir and favipiravir. HIV and COVID can both affect all the systems. Both PML and COVID can cause memory fog, personality change, etc. Both are inflammatory diseases, so the incidence of cardiac complications can be higher. Both are prothrombotic states. The diagnosis of OIs and IRIS may be challenging in co-infected patients. And also we need to bear in mind that the recent example of stigma and biases and prejudices in COVID-19, which had been provoked, made us realize of all the stigma that the HIV infected patients have been suffering for so many years, and these key populations must not bear the brunt of increased stigma and discrimination as a result of the COVID-19 pandemic. So the recommendations of these people are that they, in such a situation, they should keep an ample medication supply ready, keep vaccinations up to date, establish plan for clinical care if they are isolated or quarantined, such as telemedicine option or physician online portals. Maintain a social network, but remotely, because social contact helps us stay mentally healthy and fights boredom. And to summarize, HIV, TB, COVID has to be viewed as a high-risk population. Given the urgency of COVID-19 pandemic and the rapidly changing information about the disease, a high degree of vigilance is needed on the cause of infection in these patients. Bed control HIV patients are not associated with a poor outcome. Particular caution is needed for patients with low CD4 count, advanced disease, high viral load, and those not on ERT. TB, HIV, and COVID are immune suppressing infections and may lead to further OIs. In the future, lung lesions associated with COVID-19 will increase the risk of PTB, which induces a truly vicious circle of HIV, TB, COVID co-infection. And as people living with HIV are today living longer with ART, many of them will have chronic conditions associated with severe COVID-19. And we need to bear in mind that we need to be cautious and follow all precautions for a long time to come, because we don't know whether we are in for a second wave or a third wave. God forbid we do not. But we really need to be on the alert all the time. Thank you.
So thank you, Dr. Mala, for a wonderful presentation as usual. I think she has made it very clear the experience, her own personal experience of treating so many COVID patients in last 8 months or so, and her experience of treating other infectious disease patient also. She has presented very beautifully. I think there is a question. Are antiviral required for all COVID? This is asked by Dr. Rajan Patel. Are antivirals required for all COVID patients?
Okay, so as far as antivirals are concerned, actually it's an entire topic by itself. You require an antiviral only if the patient comes to you very early in the first 7 to 10 days, because that is the time of viral replication. A COVID patient would do well with antiviral only if he presents very early. Now, after 7 to 10 days, the patient is ill not because of the viral replication, but because of the COVID, the cytokine storm and the dysregulated immune response. Therefore, your antivirals are not going to be effective after 7 days, and there you require immunosuppression either with a broad spectrum immunosuppressant like corticosteroids or with a biologic like tocilizumab, etc. So antivirals are going to be effective only in the first 7 days. Also, there's a lot of controversy over which antiviral. Now, earlier remdesivir was supposed to be a magic bullet. Now, the WHO Solidarity trial also say that remdesivir actually is not effective, though patients are receiving. So therefore, we are not giving remdesivir to all patients. Also, remdesivir would be more effective in a patient who comes with moderate COVID and who has not yet required ventilation. So if you have a patient who comes in the first 7 days, has got a modest oxygen requirement, there probably you can consider giving remdesivir if there are no complications. But you can give it now in a patient of CKD also, and a pregnant patient also, because there is now adequate data that if the patient comes in first 7 days, then pregnancy and a CKD, if the patient is receiving dialysis, would not be a contraindication.
So thank you very much, Dr. Mala. I think we have come to the end of this seminar and CME. I request Dr. Sachin Patarkar, is he there, to propose the vote of thanks. Sachin.
Yes, sir. Good afternoon, everyone. I would like to thank our speakers of today's webinar, Dr. Suhas Agre, Dr. Preeti Mehta, Dr. Shruti Tapaiwala, Dr. Paresh Jain, Dr. A.R. Pazare, Dr. Mala Kaneria. I also thank our knowledge partners for the day, Sir H.N. Reliance Foundation Hospital, Novartis Private Limited, Mr. Dipen Mehta and Mr. Chirag from DigiShield, who have given us the platform for this webinar and handle all the technical details. At the same time, I also thank our MMC observer, Dr. Yogesh Shah, and all the delegates for participating in the webinar to make it a grand success. Thank you very much.